mechanisms in place to address the strike. They're actually right. How many of you here think that absenteeism is a very big problem in the healthcare sector? By nod of head? Almost everywhere. I'll differ. A problem bigger than absenteeism is presenteeism. And that is being at the workplace, but you're not actually focusing. Your morale is low. The gentleman is on the phone attending to a patient. Absenteeism is a big factor in the healthcare sector because, sorry to use this as an example, the healthcare sector is not like a soap manufacturing industry where there's a standard soap at the other end of the tunnel, where you whip the emotions of a doctor or a clinical officer or a nurse to attend to the patient as per protocol. When they are distracted, it's only human nature that their productivity dips, their attention dips. They're only human. So what will be our recommendations? Can you move? Our recommendations will be the opposite of the problems. We think it's just easy to extrapolate, but we found out that not. Grievance resolution by being proactive. The government tried in 2017 after a 100-day strike, but then we went again on strike in 2024, March, to address the same grievances that were apparently addressed in the 2017 strike. So there's no honesty in that pen or that paper, which keeps this suckers giving us a vicious circle of a strike, trying to solve another strike's problem. And in between, there was actually a brilliant idea that was pulled out of the hat. That happened immediately after the 2017 strike. And let me give you the figures. We said that because doctors are hard-headed, we will go to Havana, Cuba, pull 100 doctors, pay them 800,000 of our taxpayers' money, and give them a 2-year deal. Then COVID happened. We added 20 more. Out of this pool of 120, who are coming to look and digest our system and make it as smooth and freely flowing, like the one in Havana, Cuba, were family physicians mostly. Something that we didn't need as a gap, even as a stop-gap measure. The cost of that, the report or the agreement between Kenya and Cuba has never been made public. They said this is a bilateral executive order. But you can extrapolate the cost. It came to 6 billion Kenyan shillings. Then a few were abducted in the areas, in the marginalized areas, that they say doctors are not willing to go practice there. So what happened? They were all pulled out to reside in Kenya School of Government. 2 years it went. Total cost of 6 billion. 6 billion will have trained 1,667 consultants who will be here in Kenya today at a cost of 3 million per consultant. Another economic figure that I'll pull out, while we might be talking about the immediate impacts of a strike, there are other long-term impacts that you don't foresee. For instance, the child who missed his BCG vaccine, and a single jab is about 150 shillings. Might not do a follow-up. Gets exposed to TB and actually gets it, God forbid. The treatment for a normal TB case is 20,000. And for the one who missed the TB drugs, gets multi-drug resistant TB. Now the treatment for this multi-drug resistant TB is 508,992. So let's compound it. We get Cuban doctors, and our patients are also missing important vaccinations. They're missing chemotherapy, compounding onto their morbidity. Strikes have deleterious effects in the system. In the end, I think the governor was right. So was a union leader. So were the panelists. The doctor was also right. They all won their arguments. The antithesis to this is, well, right you might be, but repercussions do await. You all won. But it was a Pyrrhic victory. A Pyrrhic victory is a victory that even though you won, the losses along the way are too many to even enable you enjoy that win. Thank you very much. My name is Dr. Abidan Mwachi. I'm the National Chairman of KMPDU.
Thank you. Ladies and gentlemen, give Daktari a round of applause. I believe his speech gives us context of what our next session is going to be about. And Dr. Diana Wangari is going to be leading that panel session that is going to address the issues around UHC workforce crisis, the shortages, the brain drain, the motivation, and just focusing on strengthening the community health strategies and integration of traditional medicine in addressing the workforce shortages. So in her panel, as we prepare, we're going to have Dr. Davji Atela, the Secretary General of the Kenya Medical Practitioners and Pharmacists and Dentists Board, or abbreviated as KMPDU. He's also going to be joined on set by Mr. Peterson Washira, who is also the chairman of the Kenya Union of Clinical Officers, or KUCO in its short form, and Austin Odwor from the Global Association of Clinical Officers and Physician Associates, and they're going to really address or break down what Dr. Abidan Mwachi has talked about. And as we set up, I would like to ask my audiences, among us, I don't know, I have a passion for the young people, but I don't know how many of you who are here really wanted to be doctors when they grew up. And I'm just going to come to you guys so that we can have that conversation as they set up the stage. If I come to you, please talk. Remember to take a selfie. The hashtag is Nation Health Summit. Follow us on all the social media platforms, and let's make this interactive. I've seen you. Did you want to be a doctor growing up?
Okay, yes, at one point.
Stand up.
Yeah, thank you so much for this chance. My name is Anthony Ochieng. And yes, it's true that initially when I was growing up, at one point I really wanted to become a doctor. But because of the prevailing circumstances, at one point I had to make a shift, a U-turn, and I had to pursue something different. Thank you.
Why? Why did you shift? What really changed your plans?
Oh, what changed my plan?
Yes.
Uh-huh.
Or you choose not to say?
Well, okay, I can just touch a bit of it. Yes. So initially I wanted to do medicine, but as I was studying, probably you interact with many people. Cinder, as you interact with people, you also learn something, you also get to know things. And through some advices, obviously I used to see the doctors strike, nini nini. So I used to, I used to wonder, this is what is happening. Then I wasn't sure whether this was the right course for me to take. And probably I had to change some few things, and I'm working on other things. But I know it's a good field. For me, I normally tell people that when you're going to pursue medicine or you want to become a doctor, it's not about the money. It's because you want to help people. That is my view. Yeah, thank you.
Thank you so much. You have addressed one thing. The strikes really discouraged you in one or the other. Yes, Senior, did you want to be a doctor growing up?
Yes, indeed. You are speaking to a pseudo-doctor. My name is Joseph from Kisumu. Of course, from my physique would tell where I come from. I'm one of the people in the government. I really had a passion to be a doctor. All right. And by Form 4, I had qualified to join Udaktari, but I didn't hit the university cutoff point. Although when I went to the KMTC, I and my sister, who is my elder sister, we had qualified for all courses at the KMTC, except there was a rider. We had to, we were spoiled for choices at the KMTC because we qualified for all of them. And the reason why we were unable to is that there was someone called, I don't know whether it's right to mention someone's name in live TV. Someone called Boyd required some 40,000 for us to qualify to join KMTC. Watch I need talk. My father then, who had just retired, was required to pay 40,000 each for us to join KMTC. Well, this is a police officer who just retired and had no money to raise for the kids to join. And so we went into Polytechnic. For example, myself, I'm a qualified electrical engineer. I was registered. That course I didn't like because I wanted to do medicine. So I'm qualified, yes, but I have no passion for it. Thank you. That's where corruption has dipped us, that we have to live with it. Thank you.
Thank you very much, ladies and gentlemen. Our panel session is just about to begin, and I would like to hand this over to Dr. Diana Wangare, who is now going to run this session. But remember, what they've said is really valid. One, he saw the strikes, and he said, that's not my course. The other one qualified, but corruption came into the mix. So Dr. Diana, welcome, and please introduce your panel.
Absolutely. Thank you, Bridget. It's such unfortunate news to hear that people do want to join medicine, and then they see what's happening currently, and they say, no, this is not for me. I'm myself a medical doctor who works in a media house. I wonder if it's the same issues or there is more, right? And today with us, we have a diverse panel who in many ways are people who are on the ground, so to speak, right? Who have experiences that they're going to share with us, tell us what's happening. Is it just strikes for the sake of strikes? Is there something more happening? Are there potential solutions that we have not addressed, we are not being listened to? And it's not just from a doctor's perspective. Healthcare workforce is doctors, clinical officers, nurses. There's a whole spectrum of cadres that we do not mention. So that panel, this panel here will address those and more. And I'll start by beginning with the first panelist. I'll welcome him to the stage, Dr. Davji Atela, who's the Secretary General of the Kenya Medical Practitioner and Dentist Union. Karibu Daktari. Then I'll have Mr. Peterson Wachira, who's the Chairman of the Kenya Union of Clinical Officers. Karibu Peterson. Then we have a strong advocate for ethical health migration. Ethical health migration meaning that we're hearing that the government has signed MOUs so that then we can export nurses, we can export clinical officers. What does that mean? Yet, we have a shortage of healthcare professionals in this country. Austin, karibu to the stage. And finally, I know one of the audience members said that the reason why we're going to healthcare is because we are here to care for people. But who cares for us? You know, we are frontline workers. You saw during COVID, you have seen in many instances where we have healthcare providers offering services, yet at the same time, they're fundraising to also get services. You're seeing frontline workers dying in hospital, dying at home with no one there. Who cares for the carers? We have Dr. Musa, who's the Secretary of the Directorate of Occupational Safety and Healthcare Standards at the Ministry of Health. Karibu Daktari. Karibuni sana. We really want to make this a discussion because we were meant to have a policy expert in the room who, for many of the questions that we have here, could have answered. But I think what that does, it presents us an opportunity to paint the picture in depth, right? So that it is not madaktari, healthcare workers on strike just because they want pay. It's beyond that. And I think I will start off with Dr. Davji. Yeah? Dr. Davji, I remember I went to medical school, very much so, because I wanted to be a doctor. And my mother was like, you know what, are you sure? Why do you want to do medicine? Are you sure, right? And fast forward 10 years later, 12 years later, she tells me, are you seeing doctors on the streets every month or every other month, right? And when you try to speak to people and say doctors have real issues, most people would say, madaktari wanalipwa pesa nyingi, wako na shida gani? Yeah? So from you being the Secretary General of the Kenya Medical and Practitioners and Dentists Union, maybe it would be important for you to paint us a picture. What is the root cause of dissatisfaction? Why are doctors, why are healthcare workers, not just on the streets? What are the issues maybe we haven't addressed? What is the root cause of the dissatisfaction?
Yeah, thank you so much, Diana. It happened by luck or as planned that the keynote speaker was my chairman, and he has delved deeply on why we are on these strikes. But I want to reiterate and say that strikes are not a third world problem. 2 weeks ago, I was in Australia, Sydney, when the doctors in Australia were going on strike. And it was much different than our strike because our strike goes for long. Their strike was only for 3 days, and all the issues that they had presented, which are in a way very similar with ours, like understaffing, like the lack of issues, basic things, were done. Within 3 days, the strike was called off, and everything that they were demanding was sorted out. Their last strike before the strike of this year, 2025, was in 1982. That tells you that the problem that we are facing is not only here, and the workers' problem as doctors or as health workers is not only a Kenyan problem. The problem now becomes how the government responds to it. That is the biggest problem, because the WHO and the ILO gives framework that when you sit with health workers and agree on things that need to be implemented, you have to ensure that those things are implemented as an employer. We have collective bargaining agreements that we have signed with different employers, particularly the government. And many a times, once these things have been signed, they're left to rot in the closets. So you realize that we have many doctors across the entire country that are consultants, and that is what the posting letters indicate. But in their pay structures, they're paid as interns. We have doctors, for example, like in Kiambu, who have not seen, you may not get your salary for 3 months, 6 months, but you are expected to be in the hospitals. We have doctors who cannot afford the medical services that they themselves offer. You have to sell your land, you have to sell your car. We have situations whereby government is even trying to reduce these wages. So yes, most of the strikes that healthcare workers are going on, they're actually forced by the neglect, by the intransigency of the government. I want to also emphasize that you realize that when you make a commitment, when you make agreement, they need to be honored. The moment they're not honored, it means you are not a priority. And that's what happens in counties, that's what happens nationally. The other issue that makes doctors go on these strikes and health workers is you are in the hospital. Your primary aim is to ensure that when a patient comes in, he goes back healthy. You are not supported. You don't have the equipment that will make you diagnose a disease. Or at times you have the equipment, but you need emergency drugs to help you save the patients. They're not there. So yes, a time comes when you will be accused of neglect, but the institution has actually neglected you and not supported you to offer the services to the patients. Whenever a doctor or any healthcare worker loses a patient, there's a part of them that they lose. So yes, sometimes we go on strikes, sometimes we demonstrate, sometimes we fight so hard so that the patient that we are seeing get a quality healthcare.
But Dr. even just on that point, I'm sure the dissatisfaction is not just showcased in terms of just strikes, right? I'm sure there are other avenues where doctors, at least I'm expecting, or rather the public would say, that surely doctors have the union who can go and advocate to them to parliament, or the union members in different branches who can go advocate to local government, because there is at least a structure, right? There's a structure there. What would you say has been the challenge around advocating for the doctors?
As I said, that even legally, you cannot just wake up and go on strike. You have to engage. And even if you see our national strikes, the first one was in 2011, and then we took 7 years to go again in 2017. The next one which we had was in 2024. It means you don't go to these strikes often, nationwide strikes. But then, by the time you were going on strike, you have gone to court and litigated on the issue. You have met, you've got a letter of dispute from the Ministry of Labor showing that the employer has actually not implemented. Like today, we have a strike that is coming up in Kakamega. It's a strike which is coming because the conciliator has called the employer to sit down with the unions, and they have not turned up more than 6 months later. And then in the same hospital, we have the doctors in the maternity not able to be provided with equipment and with the drugs they need for services. So the only way, by the way, doctors don't like strikes. Doctors love being in the hospitals, just like all healthcare workers, because you love your job. But when you can't do that job in that hospital, when you are not supported to do it, both by you being paid on time, because you must drive if you're a doctor and you have a lab coat and you have a stethoscope, you can't go to a petrol station and say, I'm a doctor, now fuel my car. You can't tell your landlord that, no, I'm a doctor, I don't need to pay you the rent. You actually have to be paid for the work that you've done so that you are facilitated to be in that hospital. When those things are not done, and then you've had meetings that are not honored, you have agreements, you have court orders that are being undervalued, that are being ignored, then now you realize that you only have one thing to do. You have to bargain in a higher level. And bargaining by higher level is you to recognize your dignity. And the dignity you have is the skills. As a nurse, the skills as a doctor. Because the politicians and these governors and these leaders, you pay tax. Kenyans have paid. There's money that's been allocated in different counties. So if this has not been put as a priority for you, the only way to show that you are valuable is to withhold that service so that they can now engage with you. Otherwise, you can't, when we go on these strikes, we don't close the hospitals. They're open. So if the governor can treat, they can go and treat. If the MPs can go and they can go and, but now because you have your skills, is what you now use to bargain. By the way, strikes are cornerstone of engagement. And that's why countries that value their people, like Australia or like UK, they will not allow strikes to go beyond 3 days. But for us here, and as my chairman really explained, the political leaders have hefty medical insurances. They are governors and the ones in charge of the hospitals, they have big insurances. We have the MPs have 10 million and the likes. We have MCS. So none of them will go to the county hospitals to care whether it's working or not. So when we go on this action, the people who suffer are the public. That's why we advocate not to go on strike. It becomes a last resort. Thank you.
Okay, maybe let me switch over to Peterson, right? You are the chair of the Kenya Clinical Officers Union, right? And you cannot differentiate the doctor and clinical officer dissatisfaction because essentially you're all offering services to the public. But perhaps from your view and your opinion, you might have some suggestions on how then we address the perennial strikes. Maybe it's solutions that might not necessarily work at national level, they might work at local level. Do you have suggestions of how we could put an end to this? Because sometimes policymakers have due process that they have to follow. Would there be local solutions and national solutions?
Yeah, thank you. Thank you, Dr. Diana, and the Nation Media Group for this opportunity and the platform. And sometimes we say that probably we don't talk about health enough, and I think you're providing that platform so that we can be able to do exactly that. I want to agree with my brother Dabs here that really, as the unions, we do not like strikes. We do not like service disruptions, and our most comfortable place is actually with the patient. But then I think it would be good for us to do an analysis. regarding the human resources for health. You know, as a country, do we have a plan? Because you cannot reach a destination if you had not planned the path you are going to take so that you arrive there. And that is why right now we actually don't know where we are in terms of the human resources, because we don't even have a strategy currently. So in 2018, the late President Mwai Kibaki, His Excellency Mwai Kibaki, led this nation into rethinking its course and drafting a vision for the country. If you look at that vision, Vision 2030, there is a specific section that is for health. And when you look at the section for health, there are several things that it talks about. And I think the overarching goal was that by 2030, we are supposed to be a medical tourism destination in Africa. But then if you look at it, you know, it breaks it down into granular strategies that we were supposed to follow for us to get there. And for us to be a medical tourism destination, it says that we need to have specialized services and specialized hospitals. It says that we will need to have health workers, doctors, clinical officers, nurses, laboratory workers, and the others, specialized at the specialized level so that they can work in these facilities. We will also need to have some investment to ensure that we are training specialists. We'll also need to have a strategy on ensuring that we are staffing our facilities to have adequate numbers. So it also says that what we need to do is that we need to have a strategy for human resources of health. Now, if you look at the Ministry of Health, the last strategy for HRH that we had was between 2014 and 2018. From 2018, we do not have a revised or a strategy that we can say that it's up to date. But now, even the staffing norms and standards, which simply show how many of the health workers do we need at every level of care, at level 1, level 2, all the way to level 6. We also don't have a current one. The last one we had expired in 2018. It was from 2014 to 2018. But now, if we look at those documents, because that is where the plan is, and you know, I want to look at it from the perspective of where are we failing? And I can say that the problem that we have is we are not investing enough in health, but most especially in the human resources for health, because the human resources for health are the central pillar that then the health stands on. And then we must also realize that also health as a sector is an enabler for economic development of any society. So in the Vision 2030, we had said that we were going to put in place a strategy on how we are going to manage the human resources for health, from recruitment to how we motivate and retain them, and to how we engage them. But currently, those documents are not actually being utilized because they are supposed to inform the investment. How do they inform the investment? They inform the investment because the staffing norms and standards will provide the numbers that are actually needed. If you look at the strategy for 2014 to 2018 on HRH under the Ministry of Health, you will see by the year 2030, we require more than 11,000 doctors in the public facilities. Right now, we do not even have 6,000. I think we have 5,000. We require 23,800 clinical officers in the system. As we are talking today, we only have around 7,000. We require by today to have around 116,000 nurses in the system. These are not projections from the union, Dr. Diana. What I'm telling you is a projection from the Ministry of Health, where they had said they needed to be at in the year 2030, because it corresponds also with when the country should have achieved the universal health coverage. So what is the impact to the society? The impact to the society and to the citizenry is that when you have these shortages, you are not going to get that access to the service nearest to where you are, as we are saying, as one of the enablers of the universal health coverage. You're also not going to get that quality because you are not training enough specialists so that you can be able to access them nearest to where you are. And if that does not happen and you have to travel and look for the specialists from elsewhere, then that means that we are going to be subjected to financial harm. And now the three actually goes against the UHC objective. So what should be done and how do we get the perennial strikes? When you have these kind of shortages that are evident from the plan of the ministry, today I'm not talking about what the union want, I'm talking about what the ministry had planned and what they have done because the government works through the Ministry of Health. So when you have these numbers, if you're having, instead of having 23,000 clinic officers, you're having 7,000, it means one clinic officer is probably seeing the patients that should be seen by 3 clinic officers. What does that lead to? To what W was talking about, burnout. Then later, you find that you cannot even be motivated through promotions and are being appreciated by your employer. It leads to dissatisfaction, it leads to low morale, and the net effect is that their mental health will also be affected. They'll get into substance use. I have heard people saying that medics generally have become alcoholics. Yes, and this is because of some of these things. So how do we end perennial strikes? Because once then we get this dissatisfaction and low morale, that is what now leads to these strikes. So the thing that we need to do is to invest more. We need to increase the budget. We need to plan according to the strategy because strategies are supposed to have accompanying budgets so that if we can plan as per the strategies, we will be able to recruit enough. We will be able to pay post-basic training. We will be able to promote. And these things, these disruptions and the perennial strikes that we are getting, we are not actually going to see them.
But let me just put you on the spot because everything wants money, you know, and we do not have money, or so the government says. It's about prioritization, right? I mean, we have seen healthcare reforms that have been launched whereby we didn't have enough allocation to the primary healthcare fund, emergency chronic fund, which were meant to be funded by the government, right? We have seen not just at national level, even the allocation that's going to county has been reduced, right? And then we say we want more money and more investment into human resource for health, right? Then you bring that to me as a politician or a policy expert. Then I ask you, just a simple basic question, right? I ask, how do you propose we go about this, right? And I know you're not a policy expert, yeah? But is there a tangible, maybe step one that you'd say this investment we can start off with? For example, maybe reducing the number of people who are entering medical school so that we focus on remuneration of the people who, for example, are currently there. Would you have any suggestions? They don't have to be concrete based on data, but just some suggestions. So that then if you're talking and saying, okay, what's your proposed solution? Where do you start?
Thank you. And I think the problem is that we have a disconnect. We really need to make an investment case for health. Most of the politicians look at health as a liability, as a consumer of the budget instead of something that facilitates us to get more. And probably the disconnect there is that the politicians who are the leaders and who take care of the budget have never seen health as a facilitator. But what I would say is how much money are we losing as our people then, as we have that increased traffic to the Asian countries and the West looking for these medical services? How much money would we then gain as a country, and how much would it spur the economy if we were to get to where Vision 2030 says, so that we have other people coming now from other countries across Africa for medical tourism in Kenya? They are going to bring foreign exchange in the country. It is going to spur the economy. But also, some of the solutions we can actually get from within. Because if you look at the Social Health Authority and the funding model, it presents opportunities. There is a lot of money that we are collecting there that I feel that some of it might actually go unutilized because of how we have organized our financing model. Why can't we have some of the money that we are collecting from the Social Health Authority also go into investing into the human resources for health, whether it's recruitment or not? And you know, the amount of money that is required to actually manage the health workers is not that much. If we stopped the concrete work, the building of the hospitals, and buying some of the equipments where probably they are not needed or there are no people to operate, and invest first in the health workers, I believe we have enough money that in a phased out way, we can actually be able to improve our budgets annually and be able to reach the target and to reach the adequate staffing norms.
Surely you're not suggesting that we have to stop building hospitals. We have to build hospitals so that we cut more ribbons, so that we can say this is how healthcare service is expanded.
Now what I'm saying, we are building so many dispensaries and health centers, but we don't have health workers to work there. So what for? You know, you'd rather have a nurse or a clinical officer working under a tree, because we can still treat them under a tree, rather than have concrete walls without a health worker and equipment and medicines inside. So what I'm saying is that our investments must be logical. And you know, sometimes these facilities that we are building, they are not actually motivated by the need to have probably access, where we say for every 5,000 people you have a dispensary, for every 10,000 you have a health center. Most of them, we know that it's motivated by tenders and the kickbacks. And I think it's a conversation that we must have. But what I'm trying to say is that as a country, we must start looking at health as a facilitator of economic growth, because we say for every $1, maybe we say 1 shilling, that you put out there in prevention, for example, you save 9. The 9 that you are going to save, the money that you also save that was going outside, it's going to come into the economy. It's going to bring more employment. If we employ health workers, they're also taxpayers. They're also going to consume goods. We are going to pay more of the taxes, and we are going to spur the economy. So I think what we have not been able to do, and probably this is a challenge to ourselves as the unionists and also to the ministry, is that we must be able to make a very good case for the HRH and the health in general, so that then the parliament can be seeing health as an investment rather than a liability.
Absolutely, and I think also it's not just a factor around, and it's also because I'm a doctor here as well, just speaking, but maybe it might not be, we have not been the best at communicating our message. Maybe not just to parliamentarians, policy experts, but also to the public, right? Because just today, someone was asking me, I mean, yes, the guys for the union we see on TV every day are coming, yes? They're here to issue another strike, and I'm sure the person was here saying, oh, Kakamega is about to strike, you know? But the point is that maybe to your point, and I like that point around being able to communicate it based on needs, right? That you've said something important, that before the facility, the healthcare worker with the expertise can render it without the latest necessarily equipment or the 6-story building, you know? And maybe that communication is something that then we need to put out there so that people understand we're not just striking for more money. We're not just saying that hospitals are there and we're not willing to go, you know, because that's what a politician has been heard saying before. Other people have said the hospital is there. It's the healthcare workers who are refusing to go to the hospital, you know. And we'll come back to that even with Davji, because I just want to switch the point now, because we are seeing...
Yeah, if I can just add 1 point.
1 point.
Yes. Maybe on that investment and how we can be able to save money so that we also make health manageable in terms of the budgets. You know, there is a conversation about the community health promoters, who are very important. And we are talking about them preventing disease. But the truth of the matter is that the community health promoters cannot be able to do primary prevention because they don't have that capacity. And I want to explain. What they do is actually secondary prevention, because what we have empowered them to do is to scout for those people who are sick and bring them to the hospitals. So they are doing secondary prevention. But for you to be able to do primary prevention, you must have the people with the know-how. You must have that public health worker go to that community, look at the water sources, look at the sanitation. 75% of the diseases that come to us at the level 2 and level 3, they are water related. They are water and sanitation related. If we were to get our public health officers, get requisite numbers and get them to work down there and in the community. If we were to get a nutritionist and a clinician to be able to go there, to go to the ECDs and the other institutions, to look at the children that we have there, to look at the risk factors within the communities and the families, we will be able to empower those people and the communities to prevent probably 75% of the diseases that come to the hospitals. That will reduce the burden. Then we will be able to use that money to employ enough health workers, and we'll also be able to take them back to be able to specialize, so that then we can now have the specialized level 6 facilities that is going to attract that medical tourism to Kenya. Thank you.
Hi, there's a point that we'll come back to, because I want us to switch gear to Austin, right? Because we're seeing the government signing MOUs and different agreements saying that Kenyans can now apply, Kenya healthcare professionals can apply for positions in Western countries, Asia Pacific countries, and we're saying that we're opening up Kenya in many ways to export professionals when we have a shortage. So many people would ask, is this actually a good thing? And how could it be a good thing, right? Because it goes back to a point that it's a good thing for an individual who perhaps gets this job. But from a systems perspective, from the country perspective, we cannot see a positive. Or are we wrong? Is there a positive to exporting healthcare workers?
Thank you so much. I'm Austin Oduor, and I want to thank NTV, the Nation Media Group, for this kind of summit. I think it's one of its kind, and there is no media station in the entire region that has done this. And I know you have presence in Tanzania and Uganda, so you can also do similar ones in Kampala and Dar es Salaam.
By the way, the team that does all this is right there. There's Zainab, there's Angela. That's the team, yeah?
Yeah. I think we'll also attend those ones in Tanzania and Uganda and any other country. And this is a thumbs up to Nation Media Group. We are an international association. We are present in 78 countries. Majority of them are in Africa. I think half of them are in Africa, and as clinical officers, in other countries, we are called physician associates. And you've seen people moving to different countries. And of course, that is something that is normal. Some are even coming here to Kenya to work, but majority are going to countries in Asia, Europe. Most of them are nurses. But there are cadres that they do think that they are also, most people believe that it's only nurses who are going. But there are also cadres like orthopedics, laboratory, and of course the clinical officers. And I want to say that the brain drain can as well be brain gain if it is tackled in a very nice way. There needs to be a legislative format or way that this can be tackled. We come up with maybe something like a labor mobility law that can, because if you are supposed to move, then it should be put in such a way that you don't move silently. You don't hide. But what is he doing there? It has to be in a structured way, where the Ministry of Health or the government of Kenya signing memorandum of understanding, MOUs, serious MOUs, not just MOUs that are being hidden under the carpet. We want to see those MOUs. What is this person going to do there? Maybe if he goes there, how long is it going to take? Will he work for 5 years and come back? And this group of people that are going, what are the remuneration there? How are they going to be, to which countries are they going to? Not going to countries where they are also facing challenges, like here in Kenya. So even as we have that brain drain, people are leaving, we should also be training the numbers that we know we can absorb. Because we have a very, very serious challenge when it comes to absorbing the health workers. That's the human resource aspect. And I've moved to more than 25 countries in Africa, and the challenges are just the same. Some people will want to say that, I want to go to Botswana. Of course, Botswana, they pay our colleagues there 4 times what we get here in Kenya. But there are also challenges there. Botswana, as we speak, is doing well when it comes to issues health. But I remember it is Kenya that sent the human resource to Botswana, in the engineering and all those aspects. And I remember how the clinical officers came to, it is Kenya that made the Botswana Parliament to amend the Health Act to include the clinical officers in that act. What happened is that when teachers and nurses, when Kenya signed a bilateral agreement by the then president of Botswana, Festus Mugai, I know now is the chancellor of Amref University. And that time they were good friends with Daniel Moi, the late president. They agreed, and a lot of teachers, nurses, were sent to Botswana. But there was this, he later on became the Minister for Local Government, Karisa Maitha, who was a clinical officer, and he was among the team that went to Botswana. So he said, the clinical officers who were there, the anesthetists that were there in Botswana by that time, there are only 2 anesthetists in Botswana. But then they agreed that they can bring anesthetists. And most of the anesthetists that were taken there were clinical officers, because medical doctors by then, even Kenya alone, it could not even be more than 5 anesthetists. So most of them were clinical officers, and that's how we added the clinical officers profession anchored in the laws of Botswana. Right now, as we speak, when it comes to management of human resource, you can't compare Kenya and Botswana. And yet we can say Botswana is a country that we really nurtured. So most people are even going to Botswana. Some will go to South Africa. Some will go to Saudi Arabia. Some are going to United Kingdom. We are just urging the government, and through the Minister for Labor, the Cabinet Secretary for Labor, that it is the time that we need to have those bilateral MOUs that are genuinely MOUs, so that even if someone is leaving the country, then that person leaves the country in a dignified way. That person leaves in a way that, not silently, and finds himself there, gets some contracts there that are not even palatable. There are contracts that you cannot even, you are just there because you feel that you really need to go and work, that it is untenable here in Kenya. Kenya here, there is a lot of, you find even people who have undergone training, health workers, the doctors, nurses, some of them are even working for less than 1,000 shillings in a day. Some of them are paid 500. Hata mtu mwenye anafanya kwa hoteli anamshinda, kwa sababu mtu hoteli anapewa chakula hata hapo ya bure akifanya kwa hoteli. So those are the things that we are facing. Anapewa chakula, transport anapewa, na baada anapewa shilingi 500. Wewe ni daktari, unapewa 500, unatumia transport yako, unatumia transport kwenda na kurudi, unapewa hiyo 500, you end up saving 200 shillings or 100. Because there are no frameworks put in place where someone, even if you want to put this person on casual employment, or you want to give this person, you want to pay this person, there should be framework where you pay even people per hour. It's Kenya here. South Africa, they're paying people per hour. They do circumcision, they're paid per hour, most of these countries. But in Kenya here, someone will put you from 8 to 6 p.m. Remember that one, the government has not even employed you. You've graduated 4 years down the line. Someone employs you, anakupatia 500 shillings kwa siku. Then you expect that person to really deliver. So I think brain drain can be changed to brain gain if we do those legislative framework in a nice way. Thank you.
Okay. I mean, you've mentioned a few countries as well. And I'm asking this question for you to think about, because you've mentioned Botswana, South Africa, yeah, a lot of Southern African countries, whereby for their system or healthcare systems, number one, they do work in very structured say if you work in the public sector, maybe private sector time is limited. There are more structures around how you can distribute your time between public and private sector. Why I say that, it's a question that actually had come up around the reason why we're also not supporting healthcare workers, right, is because then I see a doctor at Kenyatta who's there for 1 hour maybe, then they have to rush to Nairobi Hospital or to the next private hospital or the next private hospital or their private clinic, right? And this might be a question for all the panelists, that because we seemed as practitioners, right, to be more focused on our own personal gains. So in case of, public trying to advocate for us, it becomes very difficult, right? So as part of the countries you've mentioned, maybe it would be important to also give context and say that why is it that Botswana can pay 4 times? It's because then perhaps the healthcare professionals are stationed within public sector, or maybe they also work for private sector. It would be important to give that context so that people understand that it is not just a factor of comparing apples to oranges, or is it, the comparison as well. I'll come back to you as well to give us context around the countries. But Dr. Musa, you are a specialist consultant. You have seen more than most of us have. You've seen the evolution, some of those policies that Peterson was talking about around Vision 2030, strategic Kenya Health Sector Plan, the strategic plan, you're part of that, right? And it always goes back to the age-old that Kenya has good policies, right? We always have another policy that's coming up. We always have a technical working group, a task force. In fact, when Peterson was speaking here, I was like, I thought we had a HRH task force, or one or the other, 2 of them in fact, right? But somehow, things seem to be forgotten, right? We write good policies, but we forget that fundamentally, the health worker or professional who's rendering these services needs to be protected, right? In your opinion and in your experience, right, what are the pressing issues that healthcare professionals are facing in the workforce? And now we're moving away from, yes, there's compensation, but you work in occupational safety and health. You work with doctors and healthcare workers who essentially are facing challenges as not having gloves, yet they're meant to be seeing patients who have infectious diseases, right? What are these challenges from a workplace perspective that professionals are facing?
Thank you, Dr. I would like to thank the Nation Media for having this forum. I think it's a very visionary forum where we can have these kind of honest conversations among ourselves as Kenyans. Ultimately, this is our country. And whatever else we do, we shall remain Kenyans. I am a medical specialist, but I serve as the Directorate of Occupational Safety and Health. I head that institution. I've headed it for the last 6 years. And this directorate has a responsibility to administer the Occupational Safety and Health Act. And just to put it in perspective, previously, it was thought that all accidents and diseases happen in factories. And so we had an act that just looked at the manufacturing sector as a place where safety and health happens. But in keeping with the world movement, with the International Labour Organization, the realization that safety and health is important in all aspects of work led to the watershed moment of us having the Occupational Safety and Health Act, which basically brings all occupations under the ambit of safety and health, and the requirement that all workers require protection in their workplaces. So in this is a very inspirational act if you're going to think about it. Because in this act, it puts the responsibility for safety and health both in the hands of the employer and the employee. So that in the sense that it's not your employer only who now gives you safety. As an employee, or as a worker, you also do have a role to ascribe to the set standards of safety that are there in the workplace. If, for example, you're a doctor, if you are supposed to have gloves on before you do a procedure, if you're supposed to scrub, there are standard operating procedures that ensure safety. Those that are unique to your workplace, then the expectation is that you should be able to ascribe to them. So in a sense, it shares this responsibility. And in sharing this responsibility, it also encourages dialogue within the workplace. In encouraging dialogue in this workplace, there's a statutory requirement that you should have what we call a safety and health committee in the workplace. This safety and health committee must, of essence, based on the safety and health committee regulations of OSHA, constitute of both the employer and the worker. And preferably, it has to be top management with representative workers who have significant voice. A lot of institutions have expanded it to include what, in the medical settings, you'll see what they call infectious control committees, because infections are huge in the settings. But you see, you have other things beyond infections. We have people who work in ICU who have a lot of musculoskeletal issues. The nurses we see have a lot of low back issues. For example, the surgeons who stand for long hours, they will have low back issues. And increasingly in the workplace, like most other workplaces, and especially in the health sector, and if you listen behind the voice of the persons who are speaking here, who are health workers, you'll hear a lot of mental health issues. The long hours, the lack of pay for many days, the lack of support, and the rest of it. This social dialogue forum encourages then that the individual workplaces then create tailored programs that address their specific needs. So that, for example, if you're working in a factory, if you're working in a media house, if you're working in a hospital, these are very different, varied circumstances that are there. You are supposed statutorily to have at least a minimum of 4 meetings in a year, and in that meeting you're supposed to be having these kind of conversations and resolving them on an ongoing basis. Being a country that is in good standing with the International Labour Organization, we encourage social dialogue, because sometimes a lot of the issues that happen is actually lack of forums where you can actually freely express yourselves and create programs that are specifically tailored towards you. Mental health challenges have become huge, and they both emanate from the workplace, but they also emanate out of the workplace. But they can have significant effects on the persons in the workplace. And having programs that address that become also equally important. The directorate also has the responsibility of compensating persons who unfortunately get permanent disability as a result of injury or disease. And there are gazetted occupational diseases for persons who work in the health sector. And the CS responsible for labor may gazette other diseases as occupational on the advice of the National Council for OSH. And I think we had a similar discussion when we were having the COVID-19 outbreak. And I think there are persons who are health workers who got exposed during the workplace. Of course, there are the steps that take towards compensation and assessment. So in terms of saying whether do we have a policy framework, do we have a legal framework, I think the reality is that in this country, we do have a legal framework and we do have a policy framework. Can it be improved? Obviously, because everything is constantly changing. It's always morphing. The workplace is always morphing. Right now, we are grappling with the issues of platform work. We are grappling with the issues of online work. We are grappling with the issues of, is an Uber driver an employee? And which employee is this who pays the employer because he's the one who is working? And what kind of protection can he have when he's the one who registers onto the app? And it may not be exclusive to that app. He may have 3 or 4 on the same. These are global conversations that are not limited to Kenya alone. I know right now in Kenya we have a huge movement towards telemedicine. We have companies that have engaged, that are providing telemedicine services to most of the region. There are 3 or 4. What kind of protection do you give to those people who can work remotely? So, like I said, these are matters that will always be evolving. They are conversations that we must constantly have. Our policies must be reflective of this. Our practice must be reflective of this. I think from where I sit, one of the biggest challenges we have is an awareness of what legal framework and protection exists for all workers, including medical workers, and how best to be able to approach it in terms of getting the same. Because the Act is also quite clear that when you're a worker and you are exposed to a hazardous work environment, you do have a process of excusing yourself from that hazardous environment. If you're going to ask me that I'm a surgeon and I don't have gloves and I have to go ahead and do the cesarean section, you do have protection under the law. But there's a process in which you're doing that, and it's required. It's statutory, and it's in Kenya.
And does that include mental health days? Am I allowed to then say I'm having a hard day, I need a mental health break? Is that part of that framework?
I think that the framework on mental health is an ongoing conversation currently. And that's not just in Kenya. If you look at the Act, there's a reference to mental health, but there's no very specific directives and administrative processes towards it. But if you come back to the principles behind this Act, the principles of having this committee and creating mechanisms that are unique to your workplace, it is possible for you to do that.
So my employer cannot fire me if I say today I want to have, I'm not coming to work because I'm having a mental health day. Is that correct?
No, that's not what I'm saying.
Okay.
Legally, let's contextualize things. The Act does not directly say that. But as a workplace, you can create, through your committee, mechanisms that can make you be excludable from the workplace if you have what you consider to be a mental health issue. Because you also know that it's easy to take advantage of it, right?
It can just be a hard day, and that in itself, you know.
I have many days like those.
Yes, absolutely. I mean,
Yes.
I want to switch the conversation to the audience, because in many ways, one of the issues that is coming up is that perhaps as the healthcare community, we've not been good at, and I see your hand as well, we have not been good at communicating, because fundamentally, I think members of the community, the Kenyan citizen are an advocate, you know, because the politician will come and say, tumefungua hospitali hapa, sasa kutoka kesho mnaweza kuja, surgery, anything you want, it's here. Tumefungua, kuna CT machine, kuna nini, yeah? Then you go there, there's no one there, right? The politician will do that. The doctors perhaps will, and healthcare professionals will come and say, no, this is not functional. But if you have heard that there's a hospital here, there's a disconnect somewhere. Why is it that then if the hospital is there, doctors are not there, right? So we want to hear from you. How is it, and what are the challenges that you think the country is facing, yes, in terms of human resource, but how could we do better? As doctors, as nurses, as clinical officers, as people who work in the Ministry of Health, how could we do better? Yes.
Okay, so niko na microphone itatembeza, but I want to take the opportunity as a person with the mic kutupa swali kwa Dr. Atela hapo. Daktari, I'm a journalist, but in this moment I want to ask you a question as a Kenyan. Mimi ni mgonjwa, labda wewe ni daktari KNH. Nimekuja kukutafuta pale KNH hauko. Lakini kwa kliniki yako uko. Na unalipwa kila mwezi na serikali, na bado unataka serikali wa kuongeze pesa kwa sababu uko kwa streets unafanya strike. So what then justifies asking for that increase in salary if you're not in the place you're supposed to be where the government pays you to be?
Okay, good afternoon. My name is Lodlaro Lidoros. I am a public health officer. I work at Health Rights Advocacy Forum. So mine will be more of a question to the occupational safety guy. We are having a lot of mental health challenges among healthcare workers. And so I would just like to know what measures are being put in place in the health system to address the mental health challenges, including the drug, substance abuse issues, and the rising suicide cases among medical interns and healthcare workers.
And maybe can this be including the briefing sessions, supervision, and self-care practices? What are they? I would like to know about that. Thank you.
We take one more, and then the answer.
Good afternoon. My name is Situma Innocent. I'm a public relations officer, Kenya Union of Nutritionists and Dietitians. Mine is not of a question, but a contribution to addressing UHC this crisis. And our crisis basically starts from our education system and the split of the cadre. If we're going to look at it wholesomely and make it work, then it's going to work for us. For example, I'll pick an example of UK and US, how the whole system is working. Because where are we crunching? We are crunching in a manner that all these cadres, we are looking at the government to be able to disseminate and give us something to take home. How? Me as a nutritionist, I'm coming out, I have to go for internship, get employed, do my job, complete. Same way to public health, same way to doctors, same way. And the circle goes on and goes on and goes on. So as we're coming into, for example, the CBC and the education system, how? Why can't we make our medical school uniform? How? Once I'm from post, that is senior school, all of us go to medical school. Like UK, like US, all of us, medical school. After that, then we move into specialization. I'll move in to do my pharmacy, I'll move in to do my surgery, I'll move in to do my nursing and everything. After that, once we are out that way, all of us will address uniformly. And picking an example like our friends in South Africa, post now medical school, I can be paid and I'm serving the government based on the community work that I'll be doing. Then after that, I move in as a specialist. So we are going to have less of this subcategory. One, this clinical officers are striking, tomorrow nutritionists are striking, next day is public health officer, and all of it together. Then equally, in the hierarchy of the ministry, it's going to be a wholesome thing that lines, and all of us are coming in as special and professionals. For these years we've worked, we're all going to deliver and is equally okay for the government to run. But it's not something that is going to happen today or tomorrow, immediately. No. It is something we have to look at, redesign our whole structure and framework for 10, 20 years to be able to pick it through. But currently the biggest problem as stands, those split. Then two is, we also grappling, we like to go easy things as a country. We want to grab at easy things. What is the easy thing? UHC, it was a quick fix to solve some problems that were there during the COVID time and that. Then it stopped there. Now we have CHVs, quick fix, we move. Then they're not solving anything. So then, again, we'll come with something else again to solve. It's not going to help us. From the baseline route, from the medical school, upward, we move through, we develop it, we copy from other countries, how UK, US is doing, we work it through, we move it out, then we have a unified flow, then control then flows into the community. I think that is going to give us better. Thank you.
Good morning, everybody. I appreciate this session very much. My name is Emily Mkomnene, for those who have come today. I represent the community health promoters or community health workers, whichever name you may choose to address them with. I'm also a member of the National Traditional Health Practitioners Association, that is for natural medicine. My point is, or my contribution, I want to acknowledge the work that the medical fraternity does, the doctors, the nurses, and all the people in the hospitals. We interact very well with them, and I advocate that they should be very well paid and very well compensated. However, as Kenyans, we have a habit of fighting imaginary ghosts. And that's why somebody has said there, we keep on enacting new task forces, new movements to fight imaginary ghosts. For example, is it Dr. Wachira has talked about community health workers. What the community health workers are getting is a very small stipend that cannot really be able to support a doctor's pay slip. Why did we have the community health promoters being acknowledged or recognized by the government? It is for the fact that the public health sector started failing. And the first person who was there when that mama Mboga is suffering at the market, coughing continuously, and does not know that she should go for TB checkup. That's where the community health workers came in. And most of them, there were people who had been affected by diseases, either like tuberculosis or HIV or even cancer. That is where we come in, very handy. And whatever the government is doing, it's not a pay for somebody. As a community health promoter, give me a minute. The first time I went to this field, I encountered a lot of people getting infected and reinfecting family members with tuberculosis because they didn't know it was an infectious disease. And I went into educating them. I went into finding knowledge. I'm not a medical person. I didn't have any background. My background is business administration. But I went and I did a book on tuberculosis to educate the public on how do we prevent TB from infecting one person to the other. When I went to share that information with the College of Health Sciences at Kenyatta National Hospital, they told me, come and interact with our students. I was there for 2 weeks. What I saw made me feel, I wondered, is it the public who are crazy or is it the doctor who is crazy? And you find a mother carrying a baby who has swollen tonsillitis, and after the doctor has given that child a jab, what does the mother pacify the baby with? Who can tell me? With a what?
Pacify.
A lollipop or juice. And that's a baby with congested chest, running nose. And I asked, why is it happening? The parents say, I don't know. I asked the doctors why. They said, we're overwhelmed. This is the work of the public health. That's when I wrote the book, The Doctor Must Be Crazy. Not to insult the doctor, but to show the doctors are overwhelmed because they are not calling the public health into account. We as citizens, we have also neglected our responsibility to check on yourself and take care of ourselves and know that it is your responsibility to observe your health, your family members, not wait until you fall down, then you rush to the hospital. So community health promoters advocate for people to know early signs of disease, prevention, and encourage you to clean even your home area and ensure that you are healthy. Thank you very much for the good forum, nation, and I appreciate. Let's keep up. Yeah.
Hello, good afternoon. Thank you so much for this opportunity and to Nation Media Group for convening this forum so that we can discuss these issues. Now, Dr. Odwor, Mr. Odwor, Austin Odwor, had mentioned the issue of brain drain and now turned it into brain gain. And I wanted to ask, how do you think the government, as now healthcare practitioners, can be able to tap into the diaspora now as the fact that they have experience and skills that they are getting from these countries which can be a benefit unto the country? And you've also noticed that the healthcare practitioners, when they go abroad, that means that they also send money back home. So they're also contributing to the Kenyan economy. So other than brain gain and diaspora remittances, how can the government foster stronger partnerships and collaborations so that we don't miss out on the expertise, the skills that these healthcare practitioners have?
Okay, we'll first let the panelists answer that as the first round, then we are coming to you again. Davji.
Yeah, thank you so much, Diana. Thanks again. I think it would be an injustice if I don't talk about community health promoters now that doctors are crazy, must be crazy. I think that the work they're doing in the hospitals to make universal healthcare, actually in the community, to make universal healthcare reality is something that cannot be underrated. Particularly the matter of sensitization of the community for the need to actually seek care when necessary, and to liaise them with the hospitals that sometimes are very dysfunctional. Those are a very important thing. And if you look at the Alma-Ata Declaration on the UHC, countries like Malawi and the Eastern Europe have strongly invested in community health promoters, which they call community health workers. One thing that needs to be done that I think Wachira brought out is that there needs to be a basic training for the community health promoters. And the other thing is the idea of stipend that government, both levels of government are putting up is actually illegal and exploitation. We believe as unions that if you are giving more than 8 hours a day to help in a particular area in the economy, in the country, you need to be paid. And that's why we have minimum wage. That's what we have been putting. I think one of the last month we gave a memorandum as a union over that. And they need to fight for that. The question that I was asked is a good question. The doctors, you go to the hospital and once you reach Kenyatta, you see a particular doctor, and that doctor is not there, is in his private clinic. This has been a notion and a propaganda that has been propagated far deep into our heads, and we tend to believe it sometimes. Because
it's propaganda.
It's one of the higher level propaganda, I must say. And I'm saying this with a lot of conviction, because when you go to the hospital in Kenyatta or to Nakuru level 5 or to any levels, the doctors are not responsible in those, they're not housed in those hospitals. You go there to offer services as a doctor. So you have a rota that has been outlined for you to be in a particular clinic at a particular time. You have to have particular procedures or theater work in particular places. But now, when you are not at your place of work, it means that you are absconding duty. It means that you need to be punished. It means that there's a problem. But when you see a county government or a chief officer or a governor or a medical superintendent coming to complain, it's an expression of incompetency from those people, because the law provides avenues for handling these matters. I am telling you, for my 14 years serving as a union leader, there's no particular day that these people have come and said, now this person was to be here at this time and is not there. It's always a propagation. That's why I'm saying it's a propaganda.
But also, remember the audience here are Kenyan citizens, right?
Yes.
Kenyan citizens who might not have the privilege of being able to go and report, you know? Because the question that Zainab very specifically asked is based on an experience, right? And I am sure members of the audience will also remark on that if I go to a facility, it might not be Kenyatta, it might be any public facility, right? I go there at around 9, right? Early morning still, isn't it? Early morning, I am told, Dr. Davji or Dr. X, Diana, whoever, is not here and is not coming today, but you can reach them on this number. And then when you reach them on this number, they say, come to my private clinic. Now, what does, me as a Kenyan, what should I do?
You see, then that becomes a problem of the system. Because when you are paid, you're paid for the work that you're doing in the hospital, setups that you're doing. And that's why when you go to hospital, and at one point, for example, Kenyatta, the hospital is to assign you to the consultation room that you're going to. There is 1, 2, 3, based on the doctors that are available at the administrative point. You know, you don't go to the hospital, then you're going direct to see the doctor, unless you have a clinic day appointment. And that's why and this is a reality, we must be aware. You know, it's out of awareness that we create accountability. Accountability for the doctors, accountability for the nurses, accountability for the services. When we identify the individuals that are actually not offering the services when they ought to offer services, then we can solve the problem. But when we come out to say, to give blames, when in essence, we have a bigger shortage. You know, you can go to, for example, Subukia level 3 hospital or level 4 hospital, and you want to see a doctor, and you don't see a doctor there. Why? Because none has been employed there for the last 5 years. So then you come blaming that we've not been able to see a doctor, yet there has not been employment. That also becomes an issue. So as public, as members of the public, we must be able to bring our leaders that we've elected, the counties, and everybody to account. if you go to these hospitals, they also have these, they call them the numbers that you can report issues. If the doctor gives you an appointment for a clinic day, the date that you're supposed to be there, then they're not there, then that becomes a problem. That has to be sorted out.
So we should report doctors who don't show up or people who
In case there is reality of that happening.
Should we report it in the news, or you'll say it's negative press as well?
No.
No, Peterson, no, it was a rhetoric question. Peterson,
yeah,
yes.
can I also contribute to that? And I think the first thing is that we must agree that sometimes that happens. But there are three ways of sorting that. And you see, it amounts to what we are talking about. If the working environment is not conducive, if I don't feel I have the equipment I should be having, and then the right of the patients, the right of that patient in that private and that patient in the facilities. And I think, as Davji is saying, the problem with the system. The problem I see with the system, I will go to KNH, and I will be booked probably 8 months after I have booked. That is when I'm supposed to have my surgery. But then, this consultant cannot change that date because it's a system issue. It's not himself. But then he has somewhere else where he can be able to address, and probably on my side, it might be life-saving. So it's a balance, and I'm not trying to defend them. But
and you know you're part of the system, right?
Yeah.
It's not the system is here and you are here as well.
My solution would be, number one, make the working environment conducive. Number two, why is this person going to those private facilities? They're looking for money. Pay them well. Pay them that good money so that they can stay in that facility. And number three, please train enough specialists. If you know it's a mismatch between supply and demand. If you're going to have enough specialists so that you have the private sector, there are those who are employed full-time. The public sector, you have those who are employed full-time. You are going to sort it, because I know we can give very good idealistic answers here, but they're not going to sort it. Have enough specialists and you're going to sort that problem. The second thing, I think from my sister, about the CHPs. I'm not saying that they should not be there and that they should be replaced with the health workers. I really appreciate the work of the community health promoters. But remember, community health promoters do health promotion. Health promotion is defined by the WHO, as what she said. But the point I'm driving at is that there is a level of prevention, primary prevention, that requires expertise. That the CHPs, as currently they are, they don't have that expertise. And the only way that we can be able to do that primary prevention is then investing so that we have the people with the know-how, and then they can be able to assist the country to do that work. But otherwise, CHPs did not come with this regime. Community health workers have been there for a very long time. It's only that now they have been popularized and given another name. But they have actually been there.
Don't you think, and to your point around community health promoters, don't you think, and I think it's part of what she was alluding to, is the fact that your neighbor is the person who will know your problems, right? So if the community health worker exists within your locality, before you go to a specialist, even a clinical officer, even a dispensary level, right? Chances are the community health promoter, worker, volunteer would know the issue first of all. And chances are they will ask that provider or that healthcare or community health worker for a solution. Right? Because healthcare catches us at any one point, right? Don't you think perhaps the solution needs to be more around a network level and an integration level so that we're not relegating community health workers to be just record keepers, you know? Go and count the number of people, go get their weight, right? Because if go is to the community health worker, we should also empower the community health workers. Yes, compensate them, but empower them so that then they refer to the dispensary upward and upward. And I believe that was part of the vision around primary care networks as well, right? And maybe that's a point that needs to be addressed. What's primary care networks as well? And being able to empower people like Doctors Must Be Crazy, the author, to empower them so that then it's not about who is the healthcare professional, it's where the need first of all, right? And if we think that way, Anyway, I'm not giving you answers. I'm just...
Yeah, very true. And you know, she has brought out some two concerns that I think they really need to be addressed. Number one, she has brought out the gap that we have in the community because we do not have enough public health officers there. And that is why the issues of the TB and what have you are there in the community. And she was able to pick it up. But it's a good thing she's learned. The CHPs in my community are not as learned as her. Probably they may not pick that.
And that's why they need to be empowered.
Yeah, the second thing is about, she talked about a child who went to hospital with tonsillitis, but then the mother gave juice or the lollipop. And you know, that's a problem of shortage. Because of the shortage, we have become firefighters. You know, in the past, clinical officers during the first years, you actually worked in the community. You worked in the community preventing disease. You went to those institutions, you looked at the risk factors, and you were able to address together with the community. But because of the shortages, when the employment of the health workers was not commensurate with the population growth, we would no longer now go to the prevention bit, and then we had to rush back to the hospitals to be firefighters, to cure those who are already sick. And that is the problem we're having. So when you come to us, because as I said when I was starting, one clinical officer will see the patients that are supposed to be seen by 3 clinical officers. So I actually don't have time for explaining, because I have a line of 100 patients I have to see within 8 hours. So I may not have that time to tell you, now that this is the condition, you need to do 1, 2, 3, 4. And I assume probably it will be done at the pharmacy. But then the same problem is there at the pharmacy, because they also have a very huge line. And so these problems, they still come down to investments. Can we have investments where we have enough CHPs, as in the community health strategy? We have community health workers, being the CHAS, the public health officers, the clinician or a nurse there. The whole cascade, we have the adequate human resource staffing, and we have the skill mix that is required. That is the only way we are going to sort all these issues.
Okay, fair enough. And I know, Dav, you want to comment, but there was a question that was raised here around, I think it's healthcare practitioners' wellness, mental wellness, and the fact that, you know, we're going into, and I say we're going into substance abuse. We're seeing doctors take their own lives, you know, and not doctors, healthcare practitioners taking their own lives. And it seems that we're not having more and more of those conversations. Maybe you can comment around that, Dr. Musa.
Again, thank you very much. You know, the workplace is always in evolution. And the current evolution in the workplace reflects the evolution that is there in society. And there is a rise in mental health challenges in the community, and that would not be any different in any workplace. And similarly, in our institutions of health-seeking institutions. I think if you've been looking at the media, you heard there was a launch of a national mental health policy. This was not an idle policy. It's a policy that was underwent extensive stakeholder engagement before the launch. And following the launch of the mental health policy, we developed mental health guidelines at the workplace. And the mental health guidelines at the workplace actually were triggered by the health sector. But having been triggered by the health sector, they actually become applicable to all workplaces. Today, if you'll go to any of our mental health institutions, you'd be surprised at the huge numbers of persons who are seeking mental health assistance. It's a societal problem. So in these mental health guidelines, it seeks to entrench a process of identification of persons who may have mental health challenges, both arising from work and out of work, because you look at this worker on a holistic point of view, and seek to create, initially within the workplace, persons with whom the workplace may have taken through short periods of sensitization, who may be the initial, what you'd call first aid, but more importantly, to be able to link them with professionals. So that is there as a policy and as a guideline. Of course, the death of any policy and regulation is its implementation. So I think what has not been done very well is in creating the necessary awareness and resourcing it sufficiently for it to be known to be in existence by all persons. But in terms of the existence of the structures, that existence is there. The current conversation that is going on is whether we should go ahead and create either a code of practice or even a regulation. I think for a lot of employers, they feel making it a regulation puts a heavy responsibility of the employer, yet mental health issues may not primarily be from the employer. They may influence the job, but they may not be emanating from the employment. So there is conversation that is going on. I think, as usual, what is missing is creating the necessary linkage of knowledge of the workplace with the workers. So I think that's what I would say. Maybe let me weigh in a little on, I'm a doctor too, so the issue of primary health care and is an important conversation, because we know that it's not just cliche when we say that prevention is better than cure. Ultimately, prevention, and even in the setting where we are, when we implement the Occupational Safety and Health Act, the biggest win you hope is that nobody gets injured. The biggest win you want is that nobody gets silicosis from exposure to silica dust. The biggest win you want is that nobody gets hearing loss. The biggest win you want is that no healthcare worker comes down with tuberculosis, HIV, hepatitis B, and the rest. But when you are addressing the issue of primary prevention, I think it's important. The role of the community health worker or the promoter identifies persons who may already be having a problem. But there's a bigger conversation about the prevention of the disease. And that's a bigger public health conversation. And the bigger public health conversation therefore becomes, and I've seen it, when you're in the US, there's a big health management organization called Kaiser Permanente. It employs 14,000 doctors and a network of over 40,000 nurses. And there are times when they'll identify that they have a waterborne problem from a source of water in a community, and they'll put resources towards ensuring that water is clean for usage. So you see, in the past, we would see people who would be, for example, the rainy season is coming, you would see people going around spraying, making sure, because what we are doing now is identifying the person with a fever and telling him, you could be having malaria, and I'll direct you go to there. But there's a bigger conversation about putting the resource to ensure that that person doesn't actually get it. The bigger conversation of actually telling people that, you need to get your vaccination. Otherwise, you will get pertussis, you'll get whooping cough, you'll get tuberculosis. So that is the conversation and the resourcing that possibly would be important to have in terms of looking at the same. When you look at the common 70% of the diseases that are seen in our public institutions, the top 70% are actually waterborne. And if you look at what happened recently in the corona outbreak, the mere decision for you to wash your hands and mask up, they dried up the outpatient departments. So it tells you that there's a place where we need to put resources that we are not actually putting resources. So it's a conversation which we need to have. And in implementing the healthcare strategy, it will be a big blind spot if we do not do that.
Absolutely.
Thank you.
I know we're going to take another round of questions, and I can see, yes, and there's Austin, there was a question around brain drain and how we could potentially just also tap into the resources and the skills that healthcare practitioners who perhaps have gone outside and perhaps are returning, how could we tap into that as a resource?
Yeah, before I tackle that issue of brain drain,
briefly,
briefly, I just want to say that the issue of community health promoters, I think after this session, I will ask for that book so that I also go and...
you should sell it.
Yeah,
sell
I
it.
don't know how much you sell it, but I will get that book so that I also appreciate it. But then community health promoters are everywhere. I know of 6 countries in Africa who have community health promoters, and they are paid more than $150. Here in Kenya, we are jumping and making noise that they're being given 6,000 Kenyan shillings or around or thereabout. But other countries, just peers, the same peers as Kenya, developing countries, they are really appreciating those community health promoters, and they're paying them well. And back to the question, someone was asking about doctors or medical practitioners working in other places. You don't find them in government hospitals. If you pay them well, because I tell you, some of these countries, like Botswana and South Africa, they pay doctors 5 times what their counterparts here in Kenya do. So if they pay them well, they'll be there. It's just the issue of payment. And now to the issue of brain drain.
That is the only.
Yes, it's the issue of payment. Pay them well. If you can't give them that money, then why? Yes. But then the issue of brain drain, I'm not an advocate of brain drain. I may say I'm an advocate of brain gain. The issue of brain drain is strictly, we're having very many, like me, I'm a clinical officer, we are almost 30,000. And only 6,000 are employed by the government. The remaining 3,000 are employed by NGOs who think they pay like what the government is doing. You will end up having 20,000 clinical officers who are not having any formal employment, and just the same as nurses and those other people. And their counterparts in other countries are working and are being paid well. What do you expect them to do? You expect them to go and work for 500 shillings or 400 shillings a day, yet in other countries, they can go to those countries and earn 5 times what the clinical officers are earning here. Like in Botswana, I said they pay clinical officers 250,000. South Africa around the same, 250,000. Here we are paid 40,000 or 50,000. What do you expect them to do? And they are there, they are calling you, and you are in that leadership position. So my urge is to the Cabinet Secretary for Labor, these MOUs, like one they had signed with Germany. Right now, the United Kingdom has already appreciated, they listed around 8 countries who the clinical officers can be licensed in that country, United Kingdom. And Kenya is among the 8 countries, together with India and those other countries. You train here as a clinical officer, and then when you go there, you get licensed as a physician associate. And of course, that is what we are doing, and we're even having our next conference there in August this year. So what we are saying is that if the government can employ very many of us and pay as well, then the issue of brain drain might significantly reduce. Thank you.
Okay. Then I need to correct my brother a little bit. When he says that it's the issue of money that makes doctors not to be in the hospitals, because that is not the right thing. If you look at the services that procedures the doctors will do in an hospital, probably in private hospitals, vis-a-vis the wages that they are earning, you'll realize that the call for duty for doctors supersedes the issue of wages. And that's why the fight that you always have most of the time is to enhance quality of care that doctors have in the hospitals. I don't think it's justice to talk about UHC, or universal health care, when you're also talking about labor migrations, or rather health workers migration. Because yes, it's good for the individual doctor, the individual nurse, the individual clinical officer to migrate. But what is the outcome that we have for the Kenyans? Where will we get the doctors, the nurses, the health workers to actually help us in these particular hospitals, because we have real shortages. So it's something we have to really look at. And that's why most of us who don't see the need to go decide to fight to make healthcare in the country a priority.
Absolutely. We'll take another round of questions. We'll start from this end. Zainab has the mic actually, yeah.
Okay, thank you. Good afternoon, everyone. My name is Edwin Okoro from the State Department for Diaspora Affairs. My question is to the specialist, to the panelists seated up there. Now that you know that there's the issue of brain drain, as you call it, how do you engage the health professionals from the diaspora to invest back home, especially in the health sector?
I'm Jacob Gumi. I work for an NGO, Young Professionals for Development. We work with People's Health Movement and Health NGOs Network of Kenya. One question to Dr. Musa Nyandusi. In this country, we have 17 regulatory bodies under Minister of Health. Actually 16, I understand. 16 of them. 16 regulatory bodies under Minister of Health. They have no money, they have no adequate staff, they are understaffed. How can they be combined even into one or two? and then they decentralize to the counties so that they are able to offer services to the healthcare workers. Number two is to I don't know, maybe Austin and also Davji Atela. One of the issues is that we have new cadres of health, like the nursing aid, which is very unique and a mystery to us also. How is nursing aid also a profession under the health cadres? So, because we have seen some of the medical negligence and others in the hospitals are done by nursing aides. I don't know whether it was approved by the Minister of Health or which body approves a new cadre, so that we don't have anything emerging which is of medical negligence. And what is the purpose of having it anyway? Because we have a nurse, a full nurse, qualified nurse. Why should you have an aid to a nurse when you have a qualified nurse in this country? Thank you.
Okay, as we're taking more questions, please try limit your question to 1 or 2 at most.
Thank you. Allow me to be seated. My name is Marianne. I want to bring disability into this conversation, and I am in the private sector. I work on early intervention for children with disabilities. One of the major effects of doctors striking is the high cases of cerebral palsy in our hospitals. So you find a mother went to give birth and there were no doctors and had prolonged labor, and in result we had cerebral palsy. A baby was born and they didn't identify the baby had hydrocephalus or deformity, and in turn when they go home, when they come back for early intervention, it's too late. So how can we intervene in the fact of doctors striking causes long-term disability and in turn economic burden to the family? Another thing, we are experiencing health stigma through the clinical officers. So are the health workers practitioners trained on disability etiquette and how to handle disability? Thank you.
Hello, I'm Levi. Given the potential of using wearable technology like smartwatches to continuously monitor health outcomes and inform data-driven decisions, and considering the significant occupational challenges faced by healthcare workers, such as burnout, stress, sleep deprivation, how could a comprehensive study be designed and implemented to utilize smartwatches and advanced data analytics to continuously assess healthcare workers' physiological and behavioral indicators, for example, stress levels, sleep patterns, physical activity, heart rate variability, in relation to specific workplace factors like shift patterns, patient load, workplace interactions, in order to develop targeted interventions and evidence-based recommendations for optimizing healthcare workplace environments, like by reducing occupational hazards and ultimately improving healthcare worker well-being and retention.
Okay.
Thank you very much, moderator. My name is Steven Nyaga. I'm from the University of Nairobi, Department of Diplomacy and International Studies. I'm a part-time lecturer. I would like to direct my question to to Dr. Dev Giatella, the Secretary General of KMPDU. In what ways has the Kenya's foreign policy bridged the gap in achieving the universal health coverage in the country? You can comment this in line with the 2001 Abuja Treaty on the allocation of 15%. How is the country performing in the region? Thank you.
Okay. We'll take one last question. I can see, there are many hands. We can take maybe one from every section quickly, and you make it brief.
Good afternoon. My name is Lillian Momina from the Union of Nutritionists and Dietitians, and mine goes on basically your theme for the summit, that is basically achieving healthier populations in innovating, accelerate achievements of universal health coverage. I have listened to our speakers, and they have clearly outlined the need for collaborative investments in health. And you see, someone was complaining that doctors are competing with community health promoters, and unfortunately, even someone highlighted that community health promoters in other countries are paid better. Why are we complaining in the country because of a stipend of 6,000? But we are not clearly defining the roles of community health promoters, because these are people who are supposed to help in mapping the diseases or the conditions of the people at risk. So why are we complaining when we say that healthcare workers need to be employed so that they bridge in the gap so that we can achieve universal healthcare? And apart from that, we also need to ensure that we are vibrant in the health skill mix and also gender sensitivity. Allow me to complain as a woman, because yesterday someone said that the disparities in speakers' engagement was because they reached out and they could not find a female speaker. We are here, we are seated. So where was the invite? Asanteni sana.
Please, less than 1 minute.
Yes. Thank you very much. My name is Stanley Ngara, the African King of Condom. I'm a health promoter for the last 20 years. I've done community work. And my concern is about condom and HIV/AIDS. Number one, to Dr. Musa. HIV is no longer a performance contract at workplace. So the sensitization at workplace is no more going and is not mandatory. Number two, doctors, this is a very powerful forum. And I thank you, Nation. Why can't we make condom a medical supply so as we can avoid taxation? Because we have shortage of condoms. HIV is increasing. Doctors will be very busy with STI and supergonorrhea. But nobody is talking about condom taxation. And we have a lot of organizations that can donate condoms to us. But when they are donated, they are taxed. And we don't have. Thank you very much.
Okay, we're going to take one from the next section, please, so that we take.
Thank you very much. My name is David Mainge. I'm a member of the Lupus Foundation of Kenya. And I want to thank the nation so much because there is no better place for lupus awareness than this kind of sitting. I also thank you because you are also in education. I usually read about you in the nation. I've interacted with some schools on that. Now, lupus is a very mysterious disease. Lupus is a disease that is very little known in Kenya and in the world. Lupus is a disease that affects our girls. 90% of the patients are girls. And the disease starts when the girl is in school, on and on and on. She receives treatment from various doctors, yet it takes about 5-10 years before one doctor says, this kind of disease, I saw it somewhere, I read about it. You are treated for your lungs, you are treated for the heart, you are treated for the skin, you are treated for your hair, the hair falls out. And as a young girl, you are even afraid of going out of the house, even disappear from school because the hair has fallen out. You got flowers, butterflies on the face. So it becomes so devastating to the child, to the girl. It becomes so devastating to the family. And this girl, is stigmatized. The family is stigmatized. Sometimes they say, kuna witchcraft huko. Ile nyumba inahitaji sio daktari, wengi wanaenda kwa madaktari wa kienyeji. So my concern is, or the Lupus Foundation concern is, how do we raise awareness? The nation has tried, and I want to pose this problem, or to give this task to the two doctors particularly, Dr. Atela and Dr. Wachira, I've seen you got network all over. You got network in all the counties, and it is in the counties that girls are misdiagnosed. And for sure, I've seen deaths arising out of misdiagnosis because they are given the wrong treatment. I've seen girls and ladies dying because of delayed diagnosis. I've seen a lady who died last year, and it was at his deathbed that doctors diagnosed this to be lupus. Why? It's because even the doctors may never have seen a patient. When my wife was in all these hospitals, sometimes she was in Aga Khan, the only patient with lupus. Kenyatta, the only patient with lupus. So the doctors had to come and find out. I mean, my professor had to come and, teach his doctors, the students, this is how the disease behaves. So I'm requesting this so that I sit down. Okay. What can you do to raise more awareness in the counties? Because you have the network. And the other two doctors, wherever you are, how do you raise the awareness? The nation has assisted us. Professor Omondi Oyo and his team of about 15 rheumatologists have assisted us so much. But we seem to be forgotten. Other than the 15 doctors led by Dr. Omondi Oyo, the patients find themselves marginalized, not known. Nobody cares about them, though deaths are happening every month.
Okay.
Thank you.
That's a fair point. One last question from that section, then.
Hello, everyone. My name is Valerie Cheng. I'm a youth advocate. I work at the intersection of climate and health. Now, I feel like we cannot talk about health if we don't talk about climate, because then again, from the air we breathe, from the water we drink, and even the environment we stay in, these are all public health indicators. And so until we heal our environment, we cannot actually, we just like healing the symptoms. And so then I'll have this question about...
one question and under 1 minute, please.
Yes, thank you. Okay, so under the theme, we were integrating traditional medicine, you see. And so I'll say, as climate, threat biodiversity, which includes traditional medicinal plants. Now, how do we protect indigenous knowledge while also ensuring sustainability in medicine sourcing? And then again, while you were talking about the CSVs and their role in health, how is, we feel like these people, they're not really dealing with diverse disease outbreaks. They're also dealing with, environmental fallout. This is the heat stress and even floods. And so how is climate resilience, being factored into current health workforce strategies? Thank you.
Thank you for that. I'll have the panelists respond individually as opposed to per question, such that then you could respond to any of the questions. I'll highlight any question that we might have forgotten towards the end. I would want us to do this because we only have 10 minutes left, so I'd want us to do it as briefly as possible. Yeah, Dr. Musa, you can begin.
Thank you. I guess I'm the only government representative here, so I end up being directed questions that are in the Ministry of Health. I think about the 17 regulatory bodies. The 17 regulatory bodies essentially reflect the diverse nature of the professions that are there in Kenya and the development of the need for them to create professional regulations within themselves. So it might be quite difficult for one to say that they all go into the ambit of one big regulatory authority, because then you would still require to have the different regulatory institutions on the same. It's not my docket. I may not give you a clear answer, but generally it is hoped that professional regulatory institutions also get a budget from government, but to a larger extent that they support themselves from the professions from which they regulate. But that's my own personal opinion. That's not an opinion which carries which is the opinion from there, because that's not my docket. I think let me celebrate Condom King, because he has committed a large part of his adult life in ensuring condoms are widely available, and has been part of the HIV journey. And in the government, we've always had the AIDS control unit. And from the time when HIV was declared a national disaster, the AIDS control units were created in all public institutions and subcommittees. And there were deliberate efforts for one to continuously give education about HIV. But if you've been following the HIV conversation, the issue is now about integrating it alongside other chronic diseases. So it doesn't stand out alone, both in terms of integrating it as well as reducing the stigma around it. But the challenge is how not to lose the conversation while enabling the integration. So that's the big challenge. About performance, you know, that's the Ministry of Public Service. And I think in their wisdom, following this direction of integration, maybe that's why you see that there's no, it's still there, the funding is still there for AIDS control units, but the requirement now is that you should use it much more for promotive activities across health promotive activities, not just singling out HIV. I think those are the two questions I think that were had.
Yeah, thank you. I just want to contribute on one thing that he has said that I know we differ a little bit with Wachira on regarding the 17 different regulatory bodies. I hear my brother has been really commenting on South Africa and Botswana and even the Western countries. One thing that is different from what we have is that they have one professional body that regulates all the different cadres, and this cadres becomes, each one becomes a department within the particular body. Then that allows the peer-to-peer influence and also makes it easy for accountability, though each one of them operates independently. Then I will come to Stephen Nyaga on what he asked regarding the influence, the external influence on our healthcare space. There are those that are directly positive, like the budget declaration of the year 2001, where there was 15% budget of the budget should be going to healthcare. As at now, with these, the 2025-2026 budget, I think we are 2.3% of that is going to healthcare. That's why we keep on asking if the government is talking about universal healthcare and we are not seeing financing in similar manner, then is it a pipe dream? Because there's no way healthcare can be free. If the government does not budget for it, then the people must prepare to use out of pocket to spend on it. That's the reality. And some of the things that were also being discussed, even the Social Health Authority, with the more contributions that the Kenyans are doing, we expect more benefit packages. And that has been the reason of concern across board. You realize that it is out of the outcry of unions, the civil societies, that even the oncology package, the package on the ICU were increased. So it means we have to really come out and ask the government that if they're talking about universal health care, we need to see budgets for the same. If you look at the county budgets now, the percentage is only 9% of the entire national budget. Yet we have healthcare housed within the counties. If it is only 9%, we will still be having buildings without equipment, we'll have buildings without drugs, buildings without health workforce. So yes, it's upon us now to really put the government to account from the lower levels that yes, if we are having this conversation, it must go hand in hand with the budget. The second thing I must say that it's very sad that sometimes strike may cause long-term problems. And a lot of times we ask, who do we blame? The way my chairman was presenting in the morning. But in reality, we have a system that does not care. And that's why I was putting it that when strikes go for long, it's because the health workers have been denied justice, be it with impunious people in government. But then the outcome of it at the end of the day affects those who do not have any ability to take care of themselves. That's why we must always rise. When doctors say they're going on strike, when nurses say they're going on strike, when any healthcare worker says they're going on strike, it's not for themselves. We must all come out and put the governments accountable so that the strikes don't go for long, so that things are sorted out urgently.
Final point?
My final point is regarding the issue of the colleague asked on the nursing aides and these new cadres. I believe that trainings are always good, whatever level of training it is, but we must have a systems with scope that defines what everybody, based on their trainings, can do. I believe if somebody is trained as a nursing aide, he can really make a very good community health promoter. And that will help in some gaps within the within the setups. But then we have a reality that scopes of service is key for every country, for every services to be offered. If somebody is a surgeon, you can't bring somebody who has not gone to medical school or to be a surgeon to offer that particular procedure. That's when we are going to have unnecessary and unwarranted deaths.
Peterson, I think as you're addressing your points, make them brief, but also touch on those point raised around disability as well, and as part of the training as well, it would be important to bring that up.
Yeah, thank you. And to my lady who talked about disability, I'm really sorry if you have been stigmatized. I think one of the things that we are taught as health workers is not to stigmatize any category. And if that is the case, then I think it is good that it is also reported to the council, because that is an ethical issue, so that it can be handled. And also so that we can do support supervision to ensure that we resolve that. On the case of the lupus, and especially the diagnosis and the misdiagnosis, let me say that I want first to agree that actually misdiagnoses do occur. Why do we have misdiagnosis? Mostly it's not about the competence. Mostly it's about the fatigue at work because of the shortage I talked about. Because when you're fatigued, if you do a very fast Google search on fatigue at the workplace, you see mental crowdiness, attitude changes, and that means that that person cannot be able to process well and give you the right diagnosis. So we need to resolve that by ensuring that, one, we sensitize about lupus and the other conditions that may not be as common, and number two, but by ensuring that we don't have a lot of workloads. To my sister there who talked about the climate change, and I think she brings out a very good point, that as much as we are talking about health workers, prevention, and the expertise, we also must recognize that some of these water-related diseases will come with floods, which are as a result of climate change. So it must move beyond health and probably go to the Ministry of Environment and Natural Resources, so that we can also be able to look at the climate and how it affects healthcare. Lastly, and I think my brother Davji has said that we actually do differ on the merging of the cadres. We have done our desktop review. And most countries, you know, South Africa is just one. We have Uganda, we have Zambia, and several others in Africa. They're having a lot of infights within them that the bureaucracies do not even make them move. So actually for them, like Zambia and Uganda, they are doing a case study from Kenya, and they actually want to follow us and have individual professional regulatory bodies, where now we are talking about merging to where they are coming out of. So it's something we need to actually look at. And lastly, about the emerging health cadres, the problem is a problem that we have between the regulatory bodies and the Commission for University Education. They used the law and locked out the regulatory bodies in the health sector so that they can actually start a health-related course without having to consult the health regulator. And that is the problem. So to sort that, we must give back that power to the regulatory bodies, so that then they can be able to define the cadres that we need together with the Ministry of Health, and then we can be able to move in that line. Thank you.
And to your point, I think there was an offer here and a question as well around a large-scale study that could be utilized to gather a lot of this data. So the gentleman, we might not address the question, but Davji and Peterson certainly are people you should speak to. Lastly, Austin.
Most of the things have already been stated by my colleagues here.
Final
the
statement.
The only thing is, I'm also a union official, and one of my colleagues from the other sister union talked about the community health promoters. We are saying that they are there in those countries, and even Kenya here we have them. We can't do away with them. We just need to empower them and maybe even offer them some short kind of training, so that at least they can really also improve, because they are also having their association, they're also having, soon they will have their unions, because nowadays unions are coming up day in, day out. And lastly, about the issue of the nursing aid, it's not only here in Kenya that nurse aides are trained. I can give example of Botswana. Some go for even 1 year, some go for 6 months, and the finality on this, that 50% will want just to go outside and also train as and also work as nurse aides. Lastly, the issue of merging regulatory bodies, I think I'll also differ with the SG of KMPDU. It is practically impossible. And those countries that is mentioning, South Africa, are planning, the clinical officers there, and some cadres are also planning to have their own regulatory body. Burundi, and I can mention very many of them that are visited. Thank you.
Thank you. And you can see the issues are complex. There are multiple layers, there are diverse opinions, there are different experiences. The question always remains and goes back to the Kenyan citizen. What they want is services. Quality services, affordable services when they need it, because essentially that's the spirit of UHC. I know you have questions, and we are having another panel in the afternoon that will address some of the other questions that are more large scale, because we'll be talking about public-private partnerships in the afternoon. So please stick around. But for the panelists, thank you so much for making the time. There are members of the audience who might want to catch you for clarification, further questions. So if you can stick around, even if briefly, we'd appreciate it. And I think Nation Media will be inviting you and having more sessions. Please show up, support us as well, so that we can be part of changing the narrative as well. Asanteni sana. We'll be breaking for lunch. Please do come back. I know we did not come to a lot of the questions. I could see 4 hands. We will continue the discussions in the afternoon. Thank you so much.
So while they pose for the photo session there, ladies and gentlemen, we still need you in this session, in the afternoon session. Keep talking about the Nation Health Summit on your social media platforms. Let's reconvene after 1 hour. Remember, we have a QR code, and I'll request the technical team to really display it, because we're taking your feedback real time. And so you can chime in also on that section. And remember, the best has been saved for last, so I expect all of you and everyone else who's coming in within the KICC grounds to be here for the last session of the Nation Media Group Health Summit, that is going to be talking about the role of private hospitals, pharmaceutical companies, and health startups in achieving UHC. Thank you so much.
Hapo jana, lakini Rais William Ruto anafunga rasmi tamasha hizo hii leo. Tuachane sasa na masuala ya kaunti hiyo ya Nakuru, tuangazie mengineo, ambapo serikali ya Kenya imetangaza hatua kali za kabiliana na ajali za barabarani wakati wa msimu huu wa Pasaka. Mwenyekiti wa mamlaka ya usafirishaji wa usalama barabarani, Khatib Mwashitani, pamoja na afisa mkuu wa usalama mkoa wa Pwani, wametangaza kuanzishwa kwa operesheni ya kitaifa kuanzia Jumatano hii. Na operesheni hii inalenga kuzuia ajali na kuweka adhabu kali kwa wanaokiuka sheria za barabarani.
During holidays we have a lot of accidents, and without us planning, then we'll face the same scenarios that we've been facing. We have tasked ourselves that for these 4 days, as from Wednesday, we are going to ensure that we go to the ground and ensure that each and every law that is within the law of traffic and within the law of NTSA is enforced. And we are very much positive with the kind of plans that we've put in place.
And we'll have teams which will be moving out across the whole region, and they will be strategically placed and for the issue of enforcement and etc. Normally we have sufficient deployments in the beaches, and immediately after 6 p.m. normally we advise people to leave the beaches. So they can stay up to 6, but not any time beyond 6.
Na mtazamaji, waziri wa fedha John Mbadi anatarajiwa kufika mbele ya bunge hii leo kuelezea mbona mgao wa usawishaji wa maeneo bunge haujatolewa. Hii ni baada ya wabunge hapo jana kutishia kususia vikao vya bunge kwa kile wanadai kuwa ni kucheleweshwa kwa mgao wao. Kama anavyoarifu mwanahabari wetu Moses Wanjala, ilimlazimu spika wa bunge la kitaifa Moses Wetangula kuingilia kati na kumtaka waziri huyo kufika mbele ya bunge hii leo.
Waziri wa fedha John Mbadi anatarajiwa kufika mbele ya bunge leo alasiri, maswali chungu nzima yakimkodolea macho. Hii ni baada ya bunge kutishia kususia vikao vya bunge hapo jana kutokana na kuchelewesha kwa mgao wa fedha na kumtaka Mbadi kufika mbele yao kuelezea ni kwa nini mgao huo haujatolewa.
NGCDF is not for members of parliament. I can very well do my representation, my oversight and my legislative work as a member of parliament without NGCDF. But I know there are children in Kikuyu constituency where I come from who would not otherwise be in school today. Why not for NGCDF?
Let him come here. Let him tell us what plans he has for us. Let him come with the money. Mr. Speaker, for now, even if we suspend the business of the House, we will wait for tomorrow still for him to appear here. He will not be coming here today.
The House an opportunity tomorrow to listen to a response to a very noble point of order raised by the member for Bumula.
Hili linajiri siku chache tu baada ya kinara ODM Raila Odinga kutaja mgao huo kuwa usiokuwa halali na unaokiuka katiba, kwani kazi ya wabunge sio kutekeleza maendeleo bali ni kutunga sheria na kutathmini utendakazi wa serikali kuu. Mnamo Septemba 20 mwaka jana, jopo la majaji watatu wa mahakama kuu lilitoa uamuzi kuwa mgao huo unakiuka kifungu cha 12 cha katiba ya Kenya kinachoelezea misingi na mifumo ya fedha za umma, ila ikawaruhusu wabunge kuendelea kupata mgao huo hadi tarehe 30 Juni mwaka 2026. Mbivu na mbichi itabainika hii leo wakati waziri wa fedha John Mbadi atakapofika katika bunge la kitaifa la Syria leo kuelezea wabunge mbona fedha za ustawishaji maeneo bunge ulichelewa kuweka kwenye akaunti zao. Moses Wanjala, NTV, County ya Nairobi.
Asante sana Moses Wanjala kwa taarifa hiyo. Mtazamaji, washukiwa 5 wanadaiwa kushambulia na kuwaibia wafanyabiashara katika soko la Hayega, eneo bunge la Shinyalu katika kaunti ya Kakamega wametiwa mbaroni. Washukiwa hao ni Wilfred Shihenga, Derek Shisundi, Sylvester Savahi, Cedric Luhombi na Maklanus. Jamani, Injila. Walikamatwa katika mtaa wa Museno, Sigalagala katika msako mkali ulioongozwa na kamanda wa polisi katika kituo cha polisi cha Hayega. Maafisa hao walipata simu 20 zilizoibwa, visu na shilingi 100,000. Waathiriwa walifichua kuwa kundi hilo lilikuwa likiwahadaa wafanyabiashara na kujifanya maajenti kisha wanawaibia. Ni operesheni iliyotekelezwa baada ya wananchi kudokezea polisi ambao hawakusita kufanya uchunguzi.
5 ambao tuko na kiongozi wao anaitwa Mark. Huyu Mark ndio ananunua hizo simu na anawaelekeza waende kuiba tena.
Monday ndipo aliponipigia simu, alafu majioni hapa kitu saa 12 ndio nimletee simu, alafu akaniambia niharakisha kidogo kwa sababu saa 2 atakuwa ameshikana sana. Pale ndipo aliponipeleka pale Kabdev club yenye iko hapa Kaega, ndipo tulielewana atapochukua simu 2, alafu hapo ndipo alipokimbia na simu zangu.
Niambiwa walikuwa wameenda kupeleka simu kwa mteja ambaye hao walijua ni mteja but hawakujua huyo ndio mwizi mwenye anaenda kuwaibia.
Na muungano wa miliki wa matatu MOA wanaomba wahudumu wa magari ya uchukuzi wa umma wawe waangalifu barabarani katika msimu wa sherehe za Pasaka ili kuepuka kuongezeka kwa ajali. Rais wa MOA Albert Karagacha ametaka mamlaka ya kitaifa ya uchukuzi, usalama na usafiri NTSA kuyagatua majukumu ya hamasisho la usalama barabarani hadi katika kaunti ili kuongeza ufanisi wa kampeni hizi. Tuungane sasa na mwanahabari wetu Laban Shaban alihudhuria kikao hicho na vyombo vya habari. Laban.
Hivi punde zaidi tumezungumza na muungano wa wamiliki wa matatu nchini
ambao wanazungumza katika kipindi muhimu sana nchini, kipindi cha shamra za Pasaka. Nakumbuka kwamba katika shamra nyingi, iwe ni Januari, Disemba ama katika mwezi huu wa Aprili wakati wa Pasaka, huwa na safari nyingi sana. Wahudumu wa matatu mara nyingi kuhakikisha kwamba wanaenda safari nyingi ili kuongeza pengine mapato yao. Rais wa MOA Albert Karagasha anawataka wahudumu hawa wawe makini barabarani, wasiongeze nauli, na pia wameambia wale maabiria ambapo wanapokuwa safarini wakiona wale wahudumu wanakwenda kwa kasi, waweze kupunguza mwendo na wahakikishe kwamba kila mtu yuko salama katika wakati huu. Pia kwa sababu ya takwimu za ajali za hivi punde zaidi, katika wiki ambazo zimepita kumekuwa na ajali nyingi sana. Na licha ya kwamba ukiangalia takwimu ya mwaka uliopita kati ya Januari na Machi, na sasa hivi Januari na Machi, ni kama kumekuwa na maafa ya watu 1100 kulingana na takwimu za NTSA. Japo MOA wanasema kwamba hii hali pengine takwimu zimepunguka zaidi, lakini kila moyo ni muhimu, kwamba watu wawe waangalifu barabarani, kila mtu, si abiria wala wahudumu, kila mtu awe mwangalifu barabarani. Ndio kauli ambayo ilirindima. Tulizungumza nao na pia wakazungumza kuhusu swala muhimu ambalo lilijiri. Kumbuka NTV tuliangazia kuhusu Telvin Mburu na Benson Kana ambao walimsaidia abiria ambaye aliugua katika hospitali, lakini baadaye wakapoteza kazi yao. MOA wamethibitisha kwamba walipoteza kazi na kuna mashauriano sasa hivi ambapo watahakikisha kwamba wanarudi kazini. Hebu tusikize walichosema.
Tutafuatilia sako ile imeweza kufanya hivyo na tuweza ku make sure that hao conductor na driver wamerudisha kazini. Hatungependa mtu wote aadhirike kwa mahali yuko, kama ni kazi aweze kufanya kazi yake bila kuadhirika. Matatu Owners iko Kenya mzima na tumekubaliana kuwa mambo ya ajali tutajaribu ku make sure imepunguka, na pia tumeongelesha madereva kupitia zile sako zetu ku make sure kule kwa barabara wakuwe waangalifu, na pia tunawasihi abiria wale wanatumia magari zetu waweze kukua waangalifu barabarani. Wakiona dereva ni mlevi, wakiona dereva anaendesha gari vibaya, waweze kuripoti kwa the nearest police station so that tuweze kusaidiana na kuendelea mbele. Kama chama tunakuja na ile mpango ya kufanya mambo ya road safety Kenya mzima. Kuanzia mwezi wa 5 tutakuwa na hiyo mambo ya road safety, na tuweze kuelimisha madereva wetu na pia tuweze kuongea na wale abiria wetu ndio tuweze kuendelea mbele.
Na wakazi wa Shinyalu katika kaunti ya Kakamega wamelalamikia ongezeko la ukosefu wa usalama na kuzorota kwa biashara katika maeneo uwanja wa ndege wa Kakamega. Na uwanja huu ambao ndege zilikuwa zinatua ulifungwa Septemba mwaka jana. Hii ni baada ya kampuni ya ndege ya Skyward Express iliyokuwa ikihudumu katika uwanja huo kusitisha shughuli zake kutokana na hali duni ya uwanja huo. Wakazi hao ambao walikuwa wamiliki wa ardhi hiyo awali sasa wanaitishia kuchukua mashamba yao kufanya kilimo iwapo hatua yote haitachukuliwa kurejesha utendakazi wa uwanja huo wa ndege.
Ndege zilikuwa zinatua hapa, zilikuwa zinatusaidia vijana wa bodaboda, hata wa mama, lakini ulifungwa ghafla.
Kiwanja imekuwa sasa ya ng'ombe. Ng'ombe zimeingia usiku zinakula nyasi hapo. Watu security saa hii taa zilikuwa zinatoka Kakamega zinawaka, taa zimetolewa.
Haya mtazamaji, na baada ya taarifa hiyo ya Kakamega, zidi kuzungumza nami pia vile unijuze unajisikia vipi kuhusiana na hilo, kwa sababu kuna wale ambao wanauliza jamani, Kakamega itafika vipi bila kutua? Zungumza nami katika mitandao yetu ya kijamii @NTV Kenya, @mwakafrida, hashtag ikiwa ni NTV Adhuhuri. Kumbuka kwamba bado tunaendelea na taarifa zetu za NTV Adhuhuri. Mwelekezi ananijuza kwamba taarifa naosoma imeingia na ipo sawa. Haya, iwekeni vizuri basi nione vizuri. Twende kazi. Wanaharakati wa haki za binadamu kutoka Afrika Mashariki wamekutana mjini Nairobi ili kuwasilisha malalamishi yao dhidi ya ongezeko la dhulma kati ya wanaharakati, wanasiasa wa upinzani na raia ambao wameonekana kuzikosoa serikali na kutetea haki za jamii. Wanaharakati hao ambao walijumuisha nchi za ukanda wa Afrika Mashariki ambazo ni Kenya, Tanzania na Uganda walibaini moja baada ya nyingine visa vya dhulma katika nchi hizi tatu.
In several recent cases, individuals have been forcibly returned to their countries of origin, often into the hands of the very regimes they were fleeing from.
Activists from Uganda, Kenya, Tanzania, we affirm our collective resolve to work together to protect human rights, defend civic space, and expose violations across the region. We will not be divided by borders, intimidated by threats, or silenced by repression.
Human rights defenders play a vital role in promoting justice, accountability, and freedom, often at their personal risk.
Kwa pamoja tunalaani mauaji ya kiholela, kutoweka kwa lazima na ukamatwaji wa kiholela wa wanaharakati, vijana, viongozi wa upinzani na wakosoaji wa serikali. Utaratibu unaozidi kuenea wa kuhalalisha uonevu wa kisiasa kwa kutumia sheria za usalama au za kupambana na ugaidi.
In Kenya, opposition leaders have been repeatedly summoned, harassed or detained for addressing public rallies or criticizing government corruption. In Uganda, opposition figure Dr. Kizza Besigye was once again arrested on trumped-up charges, while youth leaders from the NUP continue to languish in jail without trial.
Na asante sana mtazamaji wangu, kwa mashabiki wote ambao wanaendelea kutazama taarifa zetu. Daktari Shiwanga anasema mimi natazama nikiwa Butere. Ramaphosa Limdede anasema mimi natazama nikiwa Voi. Alex Jivondo anasema napata taarifa hizo moja kwa moja kutoka Shelly Beach kule ni Mombasa, jamani, maeneo ya Kwale, ya Likoni kunradhi. Naye Daniel Mwangangi anasema natazama nikitoka katika kaunti ya Makueni, nikiwa ndani ya supermarket. Asante sana. Haya mtazamaji wangu, nachukua mapumziko mafupi, nitarudi na mengi zaidi. Tuendelee kuangazia tu yanayojiri katika taarifa zetu, usiende mbali.
Ngozi yako ina glow. Nilijipaka mafuta leo asubuhi nikikam, lakini skin yangu ishaparara and it looks so dull. Sis, see, it's the new Nice and Lovely Lemon Extract Body Lotion. Hiyo ndo secret yangu to a moisturized and bright skin. Usimix.
New Nice and Lovely Lemon Lotion, enriched with vitamin C and sunflower seed oil for 48-hour nourishing glow and brighter skin. Try Nice and Lovely Lemon Lotion today.
I'll have the usual on the rocks, double.
Your profile says you don't drink.
Oh, and I missed out on the silky refreshing test?
For real? For real. Well, in that case, I'll have whatever he's having.
I drink responsibly. Knock knock.
Who's there?
Del.
Del who?
Del Monte.
Real, recognize real. No added sugar, no preservatives. 100% real fruit.
Kote nchini mbele tuendelee, mbele Kenya twende mbele,
Kenya twende mbele. NCBA, go for it.
I thought it was impossible to reduce my dark marks.
For the first time, Garnier put to the test the anti-dark marks vitamin C day and night serums.
Applied day and night, they reduce dark marks faster than anything I've tried.
And helps prevent the reappearance of dark marks.
9 out of 10 agree it's the best anti-dark marks routine they've tried.
The glow is undeniable.
My skin has never looked better. That's my secret to help prevent dark marks from coming back.
Garnier Vitamin C Day and Night Serums by Garnier Naturally.
Karibu tena mtazamaji, tuendelee na taarifa zetu. Kampuni za uchimbaji madini zinazoendesha machimbo katika maeneo ya Jaribuni na Kaliang'ombe Kokotoni katika maeneo bunge ya Ganze na Rabai mtawalia katika kaunti ya Kilifi ziko taabani. Hii ni baada ya serikali kufutilia mbali vibali vyao vya utendakazi. Na katika eneo la Jaribuni takriban kampuni 15 kwa sasa shughuli zao zitasitishwa ikiwa ni kutokana na malalamishi kwamba kampuni hizo hazina faida kwa jamii zilizoko karibu na machimbo hayo. Wanajamii wakisema vilipuzi vya kulipua chimbo hizo vimekuwa na athari katika kuharibu mazingira kwa wakazi. Akitoa maagizo hayo baada ya kuzitembelea chimbo hizo, waziri wa madini na masuala ya uchumi ya maji Ali Hassan Joho alisema kuwa baadhi ya kampuni zimekiuka kanuni.
Mbali na kwamba tunalia ya kwamba tumebomolewa nyumba zetu zinanyufa, tunataka nafasi zetu za kazi ziweze kupatikana ndani ya Rabai.
Mheshimiwa Waziri, baruti zikipigwa katika hizi nyumba, hata hao wananchi wanashindwa kulala. Mawe yanaruka, yanagonga nyumba na ni hatari. Mimi ninakuomba hizi kampuni hizi 5 ambazo ziko hapa, tayari umefunga 3, lakini ninakuomba funga zote 5. License will require wewe ukae na wananchi na uwe na mkataba na wananchi na ulipe rasilimali ya mwananchi na ya county. So to avoid that, wanaenda kuweka mining permit ambaye mimi nimetoa amri leo. Hakuna mtu hapa ambaye anatosha kuwa na mining permit. Everybody must have a mining license that has a consent from the community and the county government.
Haya, tukitoka Kilifi tuangazie hili ambapo kwa zaidi ya mwongo mmoja sekta ya afya imekuwa chini ya serikali za kaunti, na kwa wakati huo huo mtazamaji, kando na sekta hiyo kukumbwa na misururu ya migomo ya hudumu wa afya, baadhi ya kaunti nchini zimekwea mlima wa kufanikisha afya kwa wote kupitia mfumo wa dijitali. Na huku shirika la habari la Nation Media Group likiandaa kongamano la kitaifa la afya, mwanahabari wetu wa masuala ya afya na sayansi Bridget Ngana alizuru baadhi ya kaunti zilizofanikisha baadhi ya nguzo za afya kwa wote, yani UHC, na ni taarifa ambayo mtazamaji tunazidi kuiangazia. Lakini kumbuka kwamba ni kongamano ambalo liling'oa nanga hapo jana katika jumba la kimataifa la mikutano la KICC hapa jijini Nairobi, kiangazia tu swala zima kuhusiana na afya kwa wote. Haya mtazamaji, nafahamishwa kwamba taarifa hiyo kidogo ni kama inakumbwa na hitilafu ya mitambo. Tutaileta taarifa hiyo kwa mdoso mrefu, lakini kwa sasa tuelekee katika kaunti ya Makueni. Haya, tusiende Makueni, turudi tena sasa katika masuala ya afya, tuangazie taarifa hiyo ya UHC.
So far, katika chumba hiki kwenye zahanati ya Sabasaba kaunti ya Murang'a, Joseph Karanja anayeugua kisukari anazungumza na mhudumu wa afya kupitia kipakatalishi. Karanja ni mmoja wa wagonjwa wa magonjwa sugu wanaotibiwa kupitia telemedicine. Kaunti ya Murang'a ikiwa ya kwanza nchini kuanzisha mfumo huu wa afya dijitali, na anakiri kuwa gharama ya matibabu yake imepungua tangu aanze kutibiwa hapa.
Ile kutibiwa yote nimetibiwa, hiyo ya telemedicine ndio imenisaidia. Juu nikikuja hapa sukari yangu ilikuwa inaanguka chini kabisa. Ilikuwa inafika hata unapata sometimes iko 2.9. Lakini toka nikuja hapa tukaanza kuimoderate vizuri sasa ikienda chini sana.
Mhudumu wa afya anayemshughulikia Karanja anaketi zaidi ya kilomita 35 katika hospitali ya kaunti ndogo ya Muriranjas. Hapa ndipo baadhi ya wahudumu wa afya wanawahudumia wagonjwa walio mashinani. Kando na kuhakikisha kwa rekodi zote za afya katika kaunti hii ya Murang'a ziko kwenye mfumo wa dijitali, wagonjwa sasa pia kaunti hii ya Murang'a wameanza kuona madaktari wao kupitia tovuti ama kinachojulikana kama telemedicine.
The biggest challenge we have in the region is diabetes and high blood pressure. Those are the diseases that fill up our wards. Telemedicine services are available in 36 of our facilities. These are patients who are able to be seen through a computer screen, and they are able to consult a doctor from the other end, right from the comfort of their village.
Kando na kushuhudia ongezeko la fedha kutokana na huduma dijitali za afya, kaunti ya Murang'a sasa inalenga akili unde, yani AI, kufanikisha shughuli za afya katika kaunti hiyo.
The level 5 hospital used to do about 100 to 150,000 shillings a day. Cash collections. A few weeks after we automated our services, this money tripled to almost 500,000 per day. So we were able to reduce the losses simply by automation.
Once we accumulate enough data, we will definitely pivot towards artificial intelligence, so that, for instance, we get an alert when the drugs levels stocks are down. We can monitor when an epidemic is about to erupt, because the system is able to tell you today how many people came to our facilities and for what diseases. So you're able to take remedial action.
Kisha tulielekea Nyanza hadi kaunti ya Kisumu. Kaunti hii inajivunia kuimarisha afya ya jamii na vituo vya afya vya mashinani. Moja ya vituo hivyo ni hiki cha Nyalenda. Tulipotembelea kituo hiki, tuliwapata kina mama wakipokea mafunzo ya lishe bora.
Angalau nimeweza kupata masomo zaidi. Kuna yale sikuwa nimejua lakini nimejua. So tumeambiwa wakati tumeshika mimba, kwa hiyo siku ya kwanza tuanzishe kliniki na tuwe tukimeza dawa za kuongeza iron like IFAS.
We thought it wise to just bring these mothers together. We learn together with them how to make the ideal food. I might be making sukuma wiki in my house, but the way I cook it, I lose all the nutrients. Or I make porridge for my baby, but the way I've made it, it loses the value.
We like talking about indicators, and maternal indicators are the best way of looking at a health system. I think this is one of the counties where maternal mortality is reduced by 30%. Nobody ever did it. Kisumu was amongst the counties with high maternal mortalities in this country. Now Kisumu is below the national average.
Kaunti hii inahofia ongezeko la maambukizi ya virusi vya ukimwi kutokana na kusitishwa kwa msaada kutoka serikali ya Marekani, yani USAID.
Kisumu is one of the counties with the highest burden of HIV, and so the stop work order definitely will affect Kisumu. It is too early even to say what impact is going to be there, because you realize this thing has come at a time when we have enough stocks of medicine up to September. Some of our staff were already on the ground, then they were given another 90 days to work. We tried to incorporate the HIV clinics into normal service delivery, so that when you are coming for your HIV care, then you can just walk in and be seen by a normal clinician.
Huko kaunti ya Laikipia, sherehe za siku ya afya duniani ziliadhimishwa eneo la Maina, serikali ya kaunti ikiandaa kambi huru ya afya kwa wakazi wa kitongoji duni eneo hilo. Tumekuja pamoja. Wengi wa wakazi hapa wakikosa kujisajili na bima ya afya ya kitaifa ya SHIF.
Unajua sisi ni watu wa kwazo kolemia. Sasa unajua mtu akienda kibarua ya 300, utaenda 300 ulipe watoto au utalesha. Kusema kweli. Sasa tuko na uzito huo. Tupunguziwe hata hiyo 300 iwe 200. Ndio ukienda kwa 300, 200, utumie 100, 200 labda upeleke kwa SHA.
Watu wakienda hospitali wasitishwe pesa, SHA inawasimamia. Juu saa zingine watu wanaenda kama hawana, unaambiwa ulete pesa, SHA haikusimamii, unarudi bila matibabu.
When we used to have NHIF, there is a time we were the best in the whole country in registration of NHIF. We want to buy almost similar ideas. And a lot of mentality has been put into people's minds that SHA does not work, SHA cannot work, SHA is not important. But we all know where we are, even globally, we cannot be able to afford health without a form of insurance.
Kulingana na shirika la afya duniani, kufanikishwa kwa afya kwa wote, yani UHC, kuna maana kuwa kila Mkenya anapata huduma za afya kwa urahisi wakati wowote bila kugharamika kifedha. Bridget Ngana, NTV.
Mtazamaji wangu, tudunde viwanjani. Timu ya taifa ya wasichana wasiozidi umri wa miaka 17 Junior Starlets wamezidisha maandalizi yao kabla ya mechi yao ya raundi ya 3 ya kufuzu kwa kombe la dunia la wanawake wachanga dhidi ya Cameroon. Mechi hiyo itachezwa Jumapili katika uwanja wa taifa wa Nyayo. Na kabla ya mechi hii, Junior Starlets walikuwa na mechi 2 za kirafiki dhidi ya timu ya taifa ya Morocco, ambapo walitoka sare mchezo mmoja na kushinda wa pili. Michezo ya kirafiki ilitoa dhihirisho muhimu na kuimarisha mbinu kwa timu kabla ya pambano hilo muhimu. Mshindi wa mechi hii ya raundi ya 3 ya mkondo miwili atakata tiketi ya kombe la dunia la wanawake wa chini ya miaka 17 ambalo litaandaliwa nchini Morocco kuanzia Oktoba tarehe 17 hadi Novemba tarehe 8 mwaka huu 2025.
Tunajua hiyo game haitakuwa rahisi cause hiyo ni first game yetu hiyo ni second round, but first game kucheza nao, but tutajitoa tu 3 points back home. Hiyo game tunajua itakuwa rahisi, but tutangangana venye itakuwa 3 points back home. Friendly tulienda kucheza Morocco, ilipiga Cameroon, so na sisi tulienda game ya kwanza tukadraw nao 1-1, game ya pili tukawafunga 2-0, so tuko na matumaini tunaweza piga Cameroon because Morocco alifunga Cameroon.
Nayo shangwe, vifijo na nderemo vilisheheni mji wa Kimilili baada ya miamba wa handiboli katika mashindano ya shule ya upili ya St. Luke's Kimilili na Moi Girls Kamusinga kurejea nyumbani. Mabingwa hao walituzwa washindi wa mchezo huo baada ya kuwashinda Kamito ya West Pokot na St. Joseph ya Kitale mtawalia. Kimilili waliwazidi mahasimu wao wa jadi Kamito kwa alama 35 kwa 17 kwenye fainali ya wanaume, huko Moi Girls wakiwalemea vipusa wa St. Joseph alama 24 kwa 14. Na kufuatia matokeo hayo, mwalimu mkuu wa shule ya Kimilili Innocent Siro ameitaka serikali kupitia Wizara ya Michezo kuwajengea kituo cha kukuza talanta katika shule hiyo.
The federations ask the government, even county government. Sahi governor tungetengeneza uwanja hapa ya handball because we are the champions of Kenya. Na sisi tunataka, this is a talent center. Tunataka a feed system. This is a talent center. The feed system in the country. Hao vijana watafutiwe kazi. They can be a team of Bungoma County in handball.
Na shirikisho la riadha humu nchini AK limeimarisha mikakati ya kukuza vipaji vya wanariadha chipukizi, hasa wanafunzi wakati huu wa likizo kupitia kambi za mazoezi kwa chipukizi kote nchini. Na katika kambi hizo za mazoezi, chipukizi hao kutoka shule mbalimbali huwa chini ya uangalizi wa makocha wazoefu pamoja na kupata motisha kutoka kwa wanariadha tajika na waliobobea. Mkurugenzi wa ukuzaji wa wanariadha chipukizi katika shirikisho hilo, Barnaba Korir, amewataka wazazi kuwaruhusu watoto wao kujiunga na kambi za mazoezi za michezo mbalimbali wakati huu wa likizo ili kuza vipaji vyao. Korir alikuwa akizungumza katika eneo la Kaptagat alikohudhuria mashindano baina ya kambi mbalimbali za mazoezi.
We realized the importance of this, and we have had now so far have camps across the country, 55 of that in all the parts. And the purpose of that is to nurture talent and to give pathway to our young athletes, especially those who are in school. So we are partnering with primary and secondary schools, and that has been very successful.
So each and every athlete that takes part today, we want to introduce them to competition because these are young ones. They are coming up. They are coming back so nicely. So they need to get to use to competitions, and that is why we are here. We are trying to help them get to know about competition. Competition is tough, so they have to get tough while they are young.
Sina la ziada mtazamaji, naweka kijiti katika taarifa zetu za NTV Adhuhuri. Niita Frida Mwaka, siku zote nitaitika na kutakia mchana mwema.
This is NTV.
Acne-prone skin? Soap is not enough. Try Pure Active, the #1 anti-pimple cleanser with salicylic acid and charcoal, proven to reduce pimple-causing germs by up to 99.5%. 3 actions: wash, scrub, mask. For pure and clear skin. Garnier Pure Active 3-in-1 Charcoal. By Garnier, naturally.
When I have back pain, I reach for 2 tablets of Panadol Extra. For fast relief of strong pain, like headache, toothache, muscle pain. And I am finally released from pain. Try Panadol for fast and effective relief from strong pain. Now available at an affordable price.
One of the greatest midfielders of his generation, the genius of Kevin De Bruyne turns football into an art form. Known for his passing, creativity, technique and venomous shooting, De Bruyne was the elegant architect behind Manchester City's golden era. But after a decade of glory at the Etihad, De Bruyne's time in Manchester is drawing to an end as he weighs up his next move.
Possessing.
I didn't confront you when I learned that you were using Debbie to spy on me and my fashion career.
Nuongo gani sasa umekame up nayo?
I am too old to be playing stupid games.
Dad has eventually done what she threatened to do.
As you're speaking, hatuko tena na Diana.
Na mimi kufanya kazi kama house help ni kwa sababu Jezebel hange afford school fees yangu. What do you mean?
To Diana.
Sensodyne gives you long-lasting protections against sensitivity. And people come in and they're like, oh, it works. I can have ice cream and I'm not in any discomfort. I recommend Sensodyne because it works. It's brilliant.
NTV, turning on your world. The following program has been rated GE. It is therefore suitable for general family viewing.
Abraham. Thank you. Good afternoon. Good afternoon. Kabla tuanze ningependa kwanza msimame. Lazima tunyoshe mwili vizuri kabla tuanze because this is the last session and yesterday I said we're here to find solutions. So get the blood flowing to your brain wherever you need it to flow, so that your thinking heart is on point. You know, the saddest bit is doing something in the afternoon right after lunch. Na hatutaki mlale. So stretch if you need to stretch, shake your body if you need to shake your body, get the blood flowing, get the energy going. So, our agenda today, you can have your seats now. Our agenda today is to summarize everything that we've done today and hopefully leave here with solutions. So as Ngana introduced me, my name is Zena Bondati, who some of you haven't had the privilege of meeting, and I'm the sustainability editor at the Nation Media Group. I'm part of the team that has helped to put this together. So my job here today is just to do something simple, to set the context for the panel that we are going to have. And this panel, titled Public-Private Partnership and the Path to Universal Health Coverage, is coming a timely and pressing topic. It's both a timely and a pressing topic, not just for Kenya, but for the health systems across the continent. Hence the reason I hope we live here with solutions, concrete solutions that we can implement. So as we gather here today, Kenya stands at a crossroad in its health reform journey. We've seen the effort that the government has tried to put in place. We've seen the challenges and the teething problem, but the aspiration for health coverage, universal health coverage, and access to essential health services for all remains unshaken. Even with all the challenges, this resolve remains unshaken. And we've seen the laws that the government has put in place, the Kenya Health Policy 2014-2030, the Social Health Insurance Act of 2023. But despite these laws in existence, let's be honest about one thing. Without serious structural transformation, then the vision remains that, a vision. And the purpose of this conversation is to move it from being a vision to an actual implementable concrete solution that will make and transform the lives of the Kenyan population. And this is where the public-private partnerships enter this conversation. Kenya's health sector has had a long history of PPPs and also faith-based providers, and roughly 50% of health services in Kenya at the moment are delivered by both private sector and health-based solutions. And this is according to the Ministry of Health, filling in the gaps that the government is lagging behind. We've seen projects such as the Managed Equipment Service, which is also a PPP, despite the challenges that that project has faced. And at the county level, these PPPs are becoming increasingly prominent, especially where governments face staffing challenges and infrastructural shortages. And in places like Isiolo, Kilifi, Kisumu, PPPs are the lifeline for these communities, getting services to the people where government is falling short. So this panel, therefore, will give us the opportunity to cut through this noise and interrogate what's working, what's not, and what must be done differently. And this panel, you'll hear from a wide range of experts, and as usual, we urge you to pay keen attention. This is the last panel of the day. Pay keen attention, note down your questions, and then engage with the panelists as they proceed. So to introduce the panel, I'd like to introduce my colleague, Dr. Diana Wangari.
Good afternoon, everyone. This is the final session. We want to end with a punch. I think we had a morning session where the audience was very interactive. We want to make this session similar. So we will also go directly to questions to the panelists. Some of them even rose up in the morning session, so it's part of the follow-up. And to kick us off, I'm going to welcome the panelists one by one. I'll start with Dr. Jyoti here, who's the head of Outreach Network at Aga Khan University Hospital, who can join us on stage. Then Dr. Gakombe, who's the chairman of the Kenya Healthcare Federation. Please come on stage. Dr. Chris Baraza, who's the Secretary and Chief Executive Officer for the Christian Hospital Association. Karibu. And Dan Mwala, who's the National Coordinator for the People's Health Movement. Karibu. My dear panelists, you've heard from Zainab. She says, we have been talking and talking. This is not the first iteration or the first time we have seen multiple PPPs being launched and no follow-through or the implementation is in question. And this panelist is really to focus as to how do we change that narrative, but more importantly, how are we ensuring accountability? Because it's members of the public, it's members of private sector, and I think the panel here represents those diverse views, right? So we'll go directly into the questions because we are talking action, not storytelling, action, right? So Dr. Gakombe, you're a system architect in many ways, right? Many Kenyans would argue that the role of the private sector is essential, right? However, it can be seen to be elitist and in many ways inaccessible, right? If majority of the people cannot afford healthcare services, then it is in many ways elitist. So the question to you is this: what's your view around the private sector involvement in PPPs? Are patients better off in terms of just healthcare service access? Yes.
Thank you, Wangari, and it's a pleasure to be here. The health is a complex subject, and oftentimes there are misunderstandings because we are looking at it from very different perspectives. Let's take, for example, the question of cost. You see, in health generally, there is an attempt, and that is what SHA is attempting to do, to separate payment and service access. Because we recognize that when people are sick, they need help. And one of the key ways to give them help is to not subject them to bills. Because when one is sick, you can't work to start with, and then you have to spend money to pay for healthcare. So when you look at cost, one has to look at it holistically. The reason somebody may say that private sector is elitist and expensive is because for the private sector, we are working on a full cost recovery. Everything from buildings, to infrastructure, to equipment, to human resources, to bank loans. Because everything is funded by those who utilize those services. And therefore they get a bill. When you go to a private hospital, a public hospital on the other hand, the care is to a large extent funded by all of us in this space, if one is a taxpayer. And therefore, whatever you pay is actually for consumables. You're not paying for labor, you're not paying for buildings, you're not paying for all the things I've mentioned. And therefore, it looks cheaper. And I'll give you a classic example. The Aga Khan, unless they have changed, charge 75,000 shillings for a PET scan, unless it's changed. Kenyatta University Teaching and Referral Hospital charges 50,000 shillings for a PET scan. The Aga Khan charges 75 to cover everything, and KU charges 50,000, despite the fact that we who are here are funding all their infrastructure cost. So in that case, who is more expensive? Is it the Aga Khan or is it KU, right? So that is one very, very important aspect of looking at it. Secondly, and that's why you must separate payment and provision. The private sector could actually provide, and by private I mean non-state, the private sector could actually provide all the care Kenyans need if there was somebody to pay the bills and pay them at an economic price. And one of the positive changes that has come with SHA is the fact that there is now a tariff council that will be independent, that will be looking at what does it cost to do a PET scan, what does it cost to do a cesarean section, and then come up with the price that the price that SHA should be paying for that particular service. And this is important because when it's not there, then we have the kind of situation we had where you're told it's 10,000 shillings to do a delivery to cover everything, it's 30,000 to do a cesarean section, and that money is not enough. And it also solves another problem because government at times works at cross purposes. If you look at the prices SHA is asking us to charge for many services, they are less, for everything, they are less than what the medical council says should be the doctor's fees.
But then the question becomes, just a quick follow-up, then would your hospital support mandatory fee caps for services covered under PPPs, right? Because if would your hospital or would private sector hospital providers, do you think they would support a fee cap?
The straight answer to that is no. And the reason is we are not in control of the cost of inputs. 80% of the things used in Kenyan hospitals are imported. Not too long ago, the dollar went to 160 to the shilling, and everything went up in price, right? Our unions are constantly looking for better pay. So we do not, as hospitals or healthcare providers, have a cap on costs, because if you're going to cap what I charge, then you must also cap my suppliers, you must cap the labor, you must cap everything else that I'm using. So it's price control all the way to the factory. What we support is that SHA offers an economic price for a service, publishes it as they are publishing it, and then many of us will work to work within that price if it is a sustainable price. And I'll give you an example. It is now 325,000 shillings or thereabouts to do a hip replacement under SHA. Right? I'm involved in two hospitals. One is called Lannan Hospital, the other one is Metropolitan. Lannan is working with that price, unless there are complications. Same as Kijabe, same as Tenwek, same as many faith-based hospitals. And we are very proud to say we will work with the SHA price. Metropolitan, on the other hand, has occasionally an additional 5%. So what would be important is to be asking how much more, this is the cap that SHA is paying, and then track the data and establish how well is that price working. How many providers are working, within that price? How many are not? And then the Tariff Council can regularly adjust the prices. And by giving Kenyan prices, and incidentally, I was involved in the effort to allow hospitals to advertise. Okay? And we put up the first hospital billboard. And some people thought it was wrong for hospitals to advertise. But advertisement is about giving customers information, right? And part of the reason people say healthcare is expensive is because you do not know any other price out there except the 2 or 3 doctors you know. If Kenyans knew how much it is to have a cesarean section in Aga Khan, how much it is in Chogoria, how much it is in Metropolitan, most people are able to make informed choices when they have an idea what something costs. So we have a cap on what SHA is paying. We are allowed to charge more, and we study to establish whether the price is working, and we allow Kenyans to know both how much SHA will pay and what is charged in various places. And SHA can take the initiative to say the following hospitals are working within their prices. So just like Facebook or Google, we move them to the top of the list so that when you are looking for a hospital, then the ones that will be available to you first are those that are within that price range.
Okay. So Dr. Jyoti, I'll come to you, and it's just to pull on that thread around how do you then reconcile the private sector objectives around making profit and as well as the ethos around universal health coverage, right? Because it's about accessibility, yet the private sector players' inbuilt motive is profit. How do you reconcile the two?
So thank you. And again, it's a pleasure to be here today. I'll echo what Doc has said today, that the private sector is not receiving funding from external sources like the public sector is, or from the public at large. Okay, so for the private sector, what's important is that we're sustainable. The profits that are generated, if we can call them that, are invested into infrastructure, into education, into better equipment. That's the only source of funding we have. So it's very important to note that for the private sector, right? Of course, in the private sector, you might have players who are only there for profit, but they are players who are there to make a sustainable healthcare environment and to improve healthcare.
Okay, fair enough. I mean, question Dan Owala, because I think what we're trying to head towards is something you've spoken towards on before, which is PPP capture, where donor and private sector player agendas drive decisions, right? Not necessarily about public health priorities or agendas around common good. Where do you see this playing out in Kenya?
Thank you for having me. Before I answer your question, I want to put it across to all of us that the UHC dream is based on principle of equity, non-discrimination, and the right to health. And we all know that all the building blocks of health are centered around people. So when we go into PPPs without factoring in the needs of the people, then we miss the entire approach, because then we make it a market model approach over the public, over health as a public good. How I see it play in Kenya, I'll speak to the mess, the big mess, managed equipment supply. It was one fit for all, top down, and the equipments were distributed equitably around all counties without factoring in things like the disease burden of other counties, without factoring in the contract the section of equity, though I didn't see the contract. I'm not sure whether any person in this country saw it. So that is another thing, the opaqueness of contracts when entered without factoring in or centering people or communities' needs in drafting the contracts. Then you find yourself where we are in. There are equipments in counties that are not being accessed by people. They are far away from communities. We have the question of cost. The opaqueness of the contract makes it even more difficult to make the whole mess thing accountable to people, because there are no redress mechanisms around it. There are no, there's little transparency and accountability mechanism. So I saw this play out in the mess. I saw it play out in the PPP around Kenyatta 300-bed capacity that was supposed to be built by the former NHIF board. So whether they are responding to the needs of the people is a big question that we need to ask each other. But PPPs have become a darling for counties, for national governments, because of the market model approach, because of the lucrative, kickbacks that comes with, a curative approach over preventive and promotive approach, and, the business model aspect of it that is driven by, the World Banks of these days and donors who are advancing the market model. Even the SHA shift we are talking about, as a movement we opposed the insurance-based model because,
because from what I'm hearing, it's almost as if PPPs then are becoming a substitute really for more political will, right? So does that, and an escape hatch for counties that don't want to invest in long-term public health systems, Would you say that that is a fair assessment? And should there be thresholds or performance standards counties must meet before entering PPPs? Because we want to focus on the solution.
Well, I would give it to counties because look at how we resource our county health systems. How much resources go there, and what options are they left with to fill in the gap is to enter into PPPs. The real miss here is not involving the people, not making it people-centered, and then making it more opaque for even, putting it into a more accountable and transparent system, and that is responsive to the people. So on one side, you would give it to them to, enter into PPPs, because PPPs are seen as are supposed ideally to be promote efficiency and be innovative in some way to complement service delivery. But the kind of market model approach that is given to it then misses the needs of the people that the PPPs are supposed to serve.
Okay, yeah. And maybe just to pick up on that point and going to Dr. Chris, because there's an element of opacity in all this, right? There's an element around accountability matrices, right? There's an element around also capacity in the counties, perhaps, right? So then maybe two direct questions before we turn it to the audience and then come back to the panel. Should Kenya require that all PPP contracts in health be made public and reviewed annually for performance and equity outcomes, right? And how do counties manage conflicts of interest when the same political elite may influence PPP approvals and benefit from them?
Yeah, thanks, Diana. And thanks for inviting me on this panel. My apologies, my voice may be a bit husky. I just want to mention that given the fact that some private entities are too small to fit within the PPP Act of 2020, in health we prefer using the word public-private collaboration. Because by strict definition, some of the agreements we have or the engagements we have may not actually fit into the strict definition of PPP. Having said that, there's a very big role of having public-private collaboration in this country. And as my senior here, Dr. Akombe, mentioned, the private sector provides a significant proportion of services in health for Kenyans, actually over 50%. So what that basically means is that we need to continuously have the government being an enabler for the private sector to increasingly offer high-quality services by providing a good environment for the private sector to actually engage. And by that, well, what that means is that when such kind of public-private collaboration or PPP engagements are being undertaken, there are two critical stages that, in my own opinion, we miss out. One is at the design stage. The design stage. To what extent do we involve the end user? And there are a number of examples that I can use to actually poke a bit of backups in terms of how that has been done. How is our public participation? I've attended a number of public participation sessions in this country. And sometimes I leave there and I feel like I should have used my time to something more constructive. Is it really public participation? Do you want to tick up a box and say it has happened? So at the design stage, we must really look at how do we engage the end user, the community, and the people who are going to benefit from these engagements before, and meaningfully so. And at that design stage, it's when now Diana will talk about what you just mentioned. It's at that design stage that you can actually be able to develop a monitoring and evaluation matrix, a performance matrix that resonates between the government, the private provider, and the end user. So it has to be a matrix of these three people, end user, private provider, and the government. And that matrix has to be agreed upon from the word go, not after implementing the PPP of whatever nature. The second thing that I wanted to just talk about is, and we've seen this for a long time, we've loosely, the private sector, other governments, for instance, the US government and Kenya government, we've loosely gotten into arrangements using MOUs that don't really bind anyone. MOUs are very loose documents that anyone can sign and doesn't give you an accountability matrix. So we need to move away from MOUs to serious public-private agreements that can bind each person, each provider, and say, yes, I'm a private provider, I have a PET scan, for instance. I can say I have a PET scan. The government says, we'll subsidize for you the materials, okay? Then Aga Khan will say, I'll be able to perform a number of PET images or PET scans, but you subsidize for me on this. The government plays part of this obligation. Aga Khan plays part of the obligation. At the end of the day, the patients benefit because the cost of production goes down. So we won't have the cost of what Dr. Akombe was saying of 75 vis-a-vis 60. Yet, in this country, we have very few PET scan machines. Why would we have patients going to India when cost is a prohibitive factor in accessing a PET scan in this country, for example? The last thing, just to mention what, on your second question, is yes, there's a lot of room. Especially government can really come in a bit more. And we, as a country, are usually very good in legislation, in passing acts of parliament that are signed. The problem usually comes in regulation. How do we regulate? How do we coordinate the monitoring of what we've put into place? A very good, for instance, PPP Act 2020. If you asked me how we are implementing that and how it's being regulated, it's a question for another day. Thank you.
Okay, and I can see Dr. Gakombe has a point he wants to raise very briefly, because I want to turn to the audience, and in particular, I want to have a rapid style fire question after your point, yeah? So go ahead, right. And panelists, let's get ready.
Thank you. I have asked for an opportunity to speak because apart from all the other things I do, I serve as the chair of the Murang'a County Health Committee, the Murang'a County's Economic Council Health Committee. And we are working very hard to deliver better healthcare for the 1 million people who live in that county. And some of you have seen it in the news. I want to make a couple of points. The first one is that healthcare is the largest PPP in this country, and celebrated. We've been a PPP since before the word PPP came to be, because right from before independence, healthcare delivery was split mainly between the faith-based providers and the government. And actually, the government was a late comer in many instances into that space. There are many places where the only facility that was available was a community facility, owned by a church, owned by the community, like the MP Shah Hospital. So when you are looking at healthcare, you need to look at it differently. There are the PPPs my brother has mentioned, the ones like the equipment scheme. But it's important we appreciate that we have been one very, very large public-private collaboration. And I'll give you two examples. Vaccination has always been accessed across the country. The primary vaccines, the vaccines come from the government. We in private sector are allowed to administer them on condition that we do not sell the vaccine. We only charge labor. And many of us have been faithful over the years to that requirement. HIV treatment, same story. We've been outlets for HIV care on condition, again, the drugs are free, just charge your labor. And many of us have been faithful to that requirement. When COVID landed here, the private sector rolled out capacity, and by private, for me, it's always non-state. We rolled out capacity much faster than the government. I ended up with a 46-bed COVID center with 13 ICU beds, because I could make decisions much faster than the government of Kenya. So, as we look at the architecture of our health system, we need to appreciate that by design, it's a PPP. Then we look now at the details of the equipment scheme, the placements for equipment, and the rest of it. Finally, part of the problem we have in the healthcare space, and we've all talked about accountability, is because the sector is opaque. And I want to remind ourselves of something we all know. Kenyan schools are public. Who serves on a school board in this space? Okay? I didn't go to Alliance. I went to a school that competes with Alliance. And we work very hard. I was 10, 20 years on the board. And we worked very hard to win in rugby, to win in sports, to win in mathematics, to win in academics. We need to get to the point where healthcare facilities, the ones he looks after, the one I run, the one she comes from, compete on outcomes. And first, clinical outcomes, and then the cost. Until we can get to that point, then everybody will be operating in darkness, and not too many good things come out of darkness.
Okay, so for accountability purposes, I want to bring Zainab and highlight spotlight on her, because she serves as the sustainability editor. She interacts with a lot of members of the public, voices of the community, from county to national as well. There's some rapid questions you have encountered that I know you want to share with the panelists. Please go ahead.
Yes, I would like to start by saying I went to Alliance. I did, no, for real, I did. So unfortunately for you, you didn't go, but we like to pride ourselves in that. So while I have the attention on you, Dr. Gakombe and Jyoti, I'd like to throw this question to both of you. You said healthcare is the biggest PPP, which by all means we all agree it is the biggest PPP. But then the question comes, whose interests? What are the profit margins? Because the concern from many people is, why is healthcare service provision ridiculously expensive in private facilities? And Dr. Gakombe started by comparing the cost of a PET scan in Aga Khan versus KUTTRH, a 20,000 shilling difference, which is a lot of money for a lot of people. And how do you also justify why a drug, I'll be prescribed a drug in one hospital, and they have a pharmacy at that hospital. I go there, the drug is 5,000 shillings. I go to another facility, the drug is 3,000 shillings. I go to another facility, the same drug, 1,000 shillings. How do you reconcile your profits versus true service to the people?
Dr. Gakombe.
Right. Let me start by saying that I live with a woman who went to Alliance, so don't ask me hard questions. And I have looked after her for 35 years. So now we are in the same WhatsApp group. The thing is, and therein lies the issue of transparency, right? That if costs were known, there is somebody comparing those costs. If outcomes were known, then someone would choose the best value proposition irrespective of ownership. Because the challenge we have now, when you cannot judge the quality of something, then you use price as a surrogate for quality, right? That is generally what happens. Something that you cannot tell the quality, then you say the more expensive one is likely to be the better quality. And that's why the quality of health bill, which is currently finding its way through Parliament, is so important. Because if there is someone who is measuring quality independently, fairly, and somebody sees the price in Aga Khan is X, the price in Metropolitan is Y, the price in Chogoria is Z, and according to their quality outcomes, they are the same, then I'll go to the one with the lowest price. Secondly, if we do not control the importation of commodities, all the way, a track and trace, all the way from manufacturer to the patient, then you see those price discrepancies, because the medicines we stock will generally be from the original manufacturer. We buy from Meds, which Chris here is involved in because they co-own it. And there are people who are also doing parallel importation. There are people who are importing counterfeits. So it is important, and there are several reforms that are going on in this sector that I think we need to be cognizant of. One is that quality of health bill. It needs to become an act, and we need to implement it and publish data about outcomes. Two is the health information exchange that is meant to track data across all facilities for all patients using the same unique identifier, so that that drug we are talking about being the same is truly the same because it has exactly the same identifier. It was not parallelly imported. But for me, the most important thing is to drive accountability is transparency. And the media and those who inform Kenyans have a critical role to play once we have that data available to publish the same way you publish school results at the end of the year. And some of us celebrate and others are not celebrating, should be the same way healthcare operates. So that the CEO in Aga Khan and myself compete on patient outcomes. Okay. That to me is the number one need.
Okay, I still wanted to hear from Jyoti about the same thing. But as you respond, I'd also like to know if you really did, if you exist to serve the people and not for profit, why you have almost zero presence in the marginalized areas which are suffering serious healthcare services shortages.
Okay, so I can't echo more with what Doc is saying over here, because pharmaceuticals, he's talked about counterfeits, he's talked about parallel imports. I mean, there's a supply chain that is supposed to be maintained. You get vaccines, you get insulins, you get cold chain, right? And who is going to check that that cold chain, when it left the manufacturer and it went to the wholesaler and it came to us and then it came to the patient, was maintained all throughout? All that costs money. Right? So when we are comparing that a drug you bought from X, Y, and Z has so much discrepancy in cost, there's a lot of factors to look into. And that's why I totally agree that the outcomes need to be measured and they need to be key performance indicators when it comes to quality. It's very, very important. Today, our regulator does not ask us to do quality accreditations. Yet, as an institution, for example, Aga Khan and many other private organizations are doing these international accreditations to validate the quality that we are talking about, because we want our patients to achieve those good outcomes. Okay? As we speak about, and going to your second question about going out there to the public, and I'll speak on behalf of Aga Khan, we have 53 medical centers. Access is one of our core values. We are trying, we are probably on this UHC pathway, right? Because it's our social mandate, not because it's a national policy. We want to create access. We are out there. We are in Meru, we are in Narok, we are in Nakuru, we are in a lot of the areas out there. And we are looking forward to these PPPs. Okay? I mean, there are PPPs that we already engage in. Are they enough? No. Instead of having sporadic PPPs, we need a sustainable PPP. So yes, the answer is, as Aga Khan University Hospital, we are out there and we want to increase our presence out there. If we combine Kisumu, Mombasa, Dar es Salaam, and Uganda, we're more than 80 medical centers out there, and we continue to grow to reach out to the population, to reach out to the public, right? We've also started offering home health services, for example, for the same reason, to create access, to go out there. You don't need to stay in the hospital for more than you need to. We can come to you. And we're using many other ways and means to create that access and to create that affordability. You know, affordability is always looked at the cost of care, but you also need to flip that coin and look at affordability, that when the private sector is coming out and coming closer to your homes, it's reducing your cost of travel. It's reducing your cost of taking time off work. There is so many factors that play to cost. And I think we need, as a nation, we need to look at it holistically. I'd also like to add that, and my colleagues have spoken about it, that when we look at these public-private partnerships, we need to look at it in a very, currently it's very fragmented, because there's the patient's needs, there is the private sector, there's the public sector, and really, sometimes we're working in parallel pathways. Instead of coming together and having this open dialogue, like we're having in a forum like this today, and saying, as one of my colleagues said, what is the need out there? Okay, what are the resources that we have invested as private sector? What are the resources that public has invested in? And how do we combine those efforts to have a healthier nation that we all want?
Zainab, sorry. Zainab, would you have a question directed to Chris Baraza, given that he works for the Christian Hospital Association of Kenya? He is also a governance expert. Would you have a question directed to him?
Yes, I'd like to know his perspectives as well on the cost of quality healthcare. And because at the end of the day, faith-based institutions tend to be affordable compared to the mainstream private hospitals. So putting in the factors that Dr. Kakombe and Jyoti are both talking about, the factors that go into the cost of this healthcare, are you facing the same challenges? And if yes, why are you still cheaper than they are?
Yeah, why are we still cheaper than they are? To answer that, I'll mention that traditionally, faith-based hospitals have come in between purely private and government in terms of cost, for a reason that there's someone somewhere who usually pays for some of the costs, as opposed to purely private, where all the costs are taken care of by the entrepreneur. In FBOs, traditionally we've had a consistent and continuous cushioning by usually donors, and especially from our mother churches. So you find that they supplement some of the costs that otherwise would be very, very expensive. There are other models where, and I'll give you an example of Turkana County, where the Catholic Church has been the alternate government for a very long time in terms of healthcare, education, and all that. And as we speak today, the county government of Turkana has a PPP arrangement with the Catholic Church where they actually give money to the Catholic Church to provide services, for a reason that some of the facilities, the government does not have a presence in some of the areas, very remote areas. And I've been in Turkana, I've been to the remotest part of that county, close to Southern Sudan, and you find there's a Catholic hospital dispensary that is being run for many years now. Point being that someone has to pay for certain costs. Either it's government or the donors that we usually have. The second thing I want to talk about in relation to this is we had this kind of arrangement for a long time between the government and FBOs until devolution happened. When devolution happened, we don't hear anything more in relation to secondment, because initially when I was an intern, for instance, I was seconded to a faith-based hospital, for example. And point being that the government could actually have some healthcare workers. Government pays, but they work in a faith-based organization or hospital. That stopped at some point. So whether we are feeling the pain, yes we are, right now as we speak, because there's no one else cushioning us from that perspective. And that's why we have to really ensure that the Social Health Authority, the SHIF, has to work, because that's the only reprieve that we have in as far as getting a bit more funding. The last thing, Diana, before I close, is that we need to understand that as a country, we exist in what I usually call a capitalistic model. So as we move towards social health insurance, and some of these cost differences that you see may be leveled off, okay? As long as we still live in a place where if Gakombe feels sick and he has money, he can walk to Aga Khan. If I don't have money, then I can't walk to Aga Khan because I can't access that service. I'll be limited by cost. But a social model will be such that he can walk to Aga Khan, I can walk to Aga Khan, despite the fact that I don't have the money, because someone else is paying for that cost. Thank you.
Diana, before I give it back to you, I wanted to ask Dan a question. Still picking up on what Chris just said, what Dr. Barasa just said. The social model that would allow me to walk to that facility. The law says I should not be denied healthcare. Emergency services should not be denied. But as the media, we can tell you we have done so many stories of people who were in an emergency and were denied healthcare because they did not have the money to pay. And even in this audience, I'm sure there'll be people with a story who will tell you something similar. So to realize this social system that Dr. Barasa is talking about, how would you envision it working so that Jyoti and Dr. Gakombe don't say, I'm providing this service, but I'm still making my money as a business person?
Thank you for the question. Yes, there are those experiences. Even as people in the civil society, we've had cases where people have lost life in ambulance, seeking admission in some of the facilities my colleagues here are running. And because of that aspect of who will pay for it, and trying to balance it with the right to emergency treatment. I think if we align their business model to public goals, then we can have a situation like what I read about in Rwanda, where there's this community-based initiative where government, through their insurance model, has expanded PPP to private providers to provide services to people who are in remote areas and what my colleague was talking about here, and even people in the low-income areas, such that when they go to those facilities, the question of who will pay doesn't arise, because there are actually some, through that PPP, some subsidies to them to allow them to expand those services. So that model to me is appealing and is worth scaling up so that we do not leave people behind or simply because they can't afford to pay. But we need also to look at our policies. Yes, we have the laws, the Act of Parliament that spoke about this right to emergency treatment. But then we need to also have a policy document that strengthens these asks that people need emergency treatment as a right. I don't know if I'm answering your question. Yes.
You are, and you mentioned a policy, lakini jana PS alikuwa hapa akisema we don't need any new policies. We have to work with what we have.
If I may, Zainab, you're asking a very, very crucial question, and it boils down to who pays for care, right? And there's something this country confused. Baraza the doctor and Baraza the healthcare operator. As a doctor, he can volunteer 50% of his time. It's a sunk cost. He's done with school. Even if he spends half the month working for free, he may still get enough to look after himself. He is not extravagant. Now, as an institution, he's buying supplies. He's buying equipment. He's paying staff. He cannot afford to do as much free work as an individual. So when clinics and healthcare facilities originally started, it was an individual doctor like me with a stethoscope and a receptionist, and we could afford to be pretty generous. But when you create an institution with a cath lab, which costs upwards of 50 million shillings, it becomes extremely difficult to render service for free. So we have to answer the question of who pays for care. Then we also answer the question of how cost-effective can it be, because we really must try to ensure that the cost is cost-effective. Point number 2, we need to study prices. I am cheaper than some faith-based hospitals, and I am sure he can agree with me, right? Why? Because some of them have also no subsidy from anyone. So we need to look at the prices and direct Kenyans by showing them information who is cheaper. Thirdly, healthcare is not very profitable. Even the largest hospital organization in Kenya, I think it's Aga Khan, are nowhere near Equity Bank, are nowhere near Cooperative Bank, are nowhere near other industries. This is a sector for social entrepreneurs. The truly profit motivated are doing other things. We are not a very profitable sector. Finally, you asked a question, why aren't we in Turkana? Why aren't we in Tana River? Why aren't we in the places that, or even in Kibra? The reason is that the unit has to be sustainable. If we get somebody who is willing to pay the Aga Khan to provide care on the shores of Lake Turkana, they will be there. So we need, once we sort out our funding model, so that patients are not the ones who are paying to access. And that's why UHC is so important. Then you find that to be able to go to places because you are no longer worried about the amount of money that economy has. And I'll give you an example. My friend Dr. Sam Thenya found a solution where there were women who have been subject to gender-based violence, they had a need and no money. So he went and convinced the likes of Safaricom, maybe even Nation contributed, other people to pay for the care. And Nairobi Women started a gender violence center because now the payment did not have to come from the person accessing service, and anybody could go there. So sort out payment, and we'll be wherever it is that we are required.
Dr.
Sorry,
Jackie,
can I add?
Want to comment?
I really want to comment.
And with a question that has come up from the audience as we're going to audience question as you're commenting, which is, how do we ensure that PPPs are not only simply substituting for weak government investment, effectively privatizing public failure? Should it be that, and this is an audience question, it's a very direct question, right? Should PPPs only be allowed after a public sector solution has been costed and ruled out? Because then private sector, as you're saying, as Gakombe has said, as Baraza has said, as Omwala has said, is that fundamentally sustainability is key, right? So a private sector player also has to look at sustainability, but it's the role of government primarily, right, to ensure that healthcare is accessible, right? So then the question becomes valid. Should PPPs only be allowed after a public sector solution has been costed and ruled out? And this is your opinion as you're commenting, and we're turning to the audience.
So before I go to your question, I want to echo what Dr. Gakombe said, because, and I'm not going to be ashamed to say this, we had gone to Wajir, and we set up a medical center in Wajir for us to do exactly what you're saying, go out to the community. Almost a year ago, we had to close down that center because we put all the funds in that center, we opened that center, we invested in equipment, in doctors, in everything, yet we were bleeding. At that point, did the public sector come in and say, you know what, you're creating accessibility, we will come in and subsidize you? That didn't happen. So as much as the private sector wants to go out there, right, as much as it wants to create affordable healthcare, which, by the way, as you look at the Aga Khan model, and we look at our hub and spoke model, we have our outreach centers, right, which are cheaper than the main hospital, 20, 30, 40% in some cases, because the cost of care at the hospital is much higher than it is at the medical centers. But what's really, really important is the clinical outcomes that my colleagues are mentioning. When you are evaluating these patients, when you're evaluating the care, when you're evaluating the quality, are you looking at these clinical outcomes? To come back to your question, would you mind, because I lost it.
Should PPPs,
The PPPs.
right, only be allowed after a public sector solution has been costed and ruled out? Right. Why? Because fundamentally, from what we're hearing, is that private sector, to ensure sustainability, someone has to pay for this care, right? And Dr. Gakombe, we're going to come back to you because you didn't answer who should pay for this care. But first, the question is this. Should PPPs only be allowed after a public sector solution has been costed and ruled out?
So I go back to that whenever a PPP is coming into question, it's a collaboration, right? So we really need to go in there and we need to look at what is required, what does the public sector have, and what can the private sector provide. If we have those three areas met, that's when we go into a PPP, right? So yes, do your costing, come and tell us what you need, look at the, remember, a partnership is never a one-way street. It's a two-way street, isn't it? So there are things the public sector has to offer which the private sector can bank on, and vice versa. So a PPP isn't a one-way street. It's a two-way street. So we need to meet all these three, and we need to come in together to have that trust, to have that collaboration, to have those clearly defined goals that we need to meet.
Dan, I want to get your opinion before we come to Gakombe. To the same question, right? Should PPPs, right, be ruled out? No, should PPPs only be an option after government initiatives have been costed and ruled out? Public sector initiatives.
Yeah, remember we're in a country where health is well enshrined in our constitution as a right to the people. So I think there should be first deliberate government costing and exhaust all mechanisms before entering into a PPP. So my answer to that is just yes.
Okay,
Yeah.
Question then, and I'll start with Gakombe before I come to Baraza. As a simple one-worded answer, who should pay for care then? And I know it's never that simple, but let's try. Who
There is
should
a very
pay?
simple answer. Everybody in this space and everybody in this country. That is the straight answer. The only issue is how we pool the money. We can pull through taxes, so you need to pay your taxes and then ask the government to account for them. We can pull through SHA, which means if you're not registered for SHA, you are not paying your bit. You can take private insurance, or you can get your employer to pay for you, or you can take your chances in going to a hospital when you have no money. The best one is that we all pay. Okay? And we are all required to pay. And if you look at those countries where healthcare works, like the UK, everybody pays through taxes. Like Japan, everybody pays through insurance. So it is everybody's responsibility to pay for healthcare. However, you can design ways for everybody to pay that make it painless for the sick and make it possible through buyer power to buy cost effectively. Because when SHA is negotiating with me, it is not the same as an individual. We are busy trying with Baraza to say, please increase another 10,000 because the money isn't enough. So we all have to pay. The mechanisms for paying is through tax and through medical pools.
Okay.
If you allow me 2 seconds, Kenya spends 500 billion shillings on healthcare. SHA is actually the icing on the cake, right? there is about 500 to 600 billion going into healthcare. Where does it come from? Your taxes, which are given to counties, who then spend 50% of their resources on health. Your taxes that go to Kenyatta Hospital, to Moi, and to KU, and to other hospitals. Your taxes that go to KEMRI. Then your private insurance that you buy through your employer or direct, because that should be part of your salary. And then there is employers who decide to take care of their staff directly. Then there are the donors who are threatening to pull out their money, so we have to find more money amongst ourselves. The thing is, our taxes are not enough to pay for healthcare for all of us, and that's why we are being asked to pay additional out of pocket. And Wangari, there is one place where money is and we never get it.
Where?
We have accident insurance. All vehicles in Kenya, including Dudhis, are supposed to be insured, right? When they hit people and they land in Aga Khan is never paid by the insurer. So among the things, you said we suggest working solutions? So among the things we are suggesting is that SHA should pay us and then go and claim from the insurer, and hopefully the insured and the insurers will find it more sensible to reduce accidents.
Okay. I want to turn to the audience. There are some audience questions. But a comment that has come from the audience as well is also, why should we pay when we are not accessing quality services? It's a rhetorical for now. Let's hear from...
Good afternoon, everyone. Good afternoon. My name is Joyce, and I have to say the healthcare system in this country is wanting. I've been in Turkana, and I can tell you for sure, government needs to step up. Your insurance will take you to the hospital that you can afford. What about this person who is down here, who cannot afford insurance, who cannot even afford SHA or she? It's wanting. And coming into it and coming to think about how funds are being misused in this country, we can be able to sustain our healthcare. We will not be even having these summits to discuss anything about health, because we'll be saying our health systems are working. It will not be fair for Dr. Kanyenje to compare Kenya with UK, US. We are getting there, but we are not there yet. But our systems have to work. My insurance can take me to Aga Khan. What about that person who is in Turkana, Garissa, Wajir? What about those women who are laboring to get children that die on their way to maternity hospitals? It is good, it looks very good when we are in uptowns. What about huko mashinani? Between public and private, who is failing who? Who is failing to come together to have collaborative measures, to have good healthcare systems? Wewe utatoka hapo utaenda Aga Khan because your card can treat you there. Mwingine atatoka hapo aende another good hospital, have dental, have your normal checkups, you know? So there is somebody who is failing our healthcare system somewhere, and it needs to be fixed. Thank you.
Okay, another question?
Good afternoon, everyone.
Good afternoon.
My name is Ogalo Ogweno. I am the chairperson for the Confraternity of Patients Kenya. Confraternity of Patients Kenya is a non-profit institution that champions for the interest of Kenyans. That is the recipients of care.
Were we with you on Monday?
No, I was in another meeting.
Oh,
in
okay.
The Kemri one, unless we met there.
Sorry.
Okay, thank you. Now, thank you. I'm sorry for the disruption. The private sector is a fundamental instrument in improving the health sector. But as was said by my good friend Owala, is that the model and how the things, the plans that are effected into it is a big issue. For instance, a good Dr. Gakombe is saying, pay for SHA and make it work. But the question is, riding on her question, the Mama Mboga, who is paying 300 shillings, contributing 300 shillings, are you able to accept her in your facility? I am also extending the same question to Aga Khan representative. The Mama Mboga and the Boda Boda man, contributing 300 shillings at the end of the month, or 500 shillings. Are you able to accept them in the facility? Number three, here we talk about quality of care. There are fundamental indicators that we're looking at. One, do we consider patient-centeredness? Because it is a matter of importance. Patient-centeredness talks about the ability, the patient to be satisfied with the services that have been offered. Indicator number two, effectiveness. Reducing mortality in these hospitals and even the number of days this person is, admitted to the facilities. Then the last indicator, allow me to finish. Then the last indicator is on patient safety, which is a key ingredient and it's an issue in our hospitals. And actually one of the driving factors to members of the public choosing the private sector is the safety concerns. As a representative of the people, the patients, the recipients of care, I interacted with the member of parliament in one of the sessions. And they outlined clearly that they like the public sector. However, their fear that drives them from the private from the public sector is the safety concerns.
Okay. We take another question from a member of the audience, and we keep it brief, please. One question so that we can have time.
I'm coming back. Please summarize your questions. Time.
Hello, everyone. My name is Dr. Brenda Kwamboka. I'm a pharmacist. I'm also a digital content creator, but specifically in digital health consultancy, digital health marketing, health tech, health policy. So today, I realize the theme is towards a healthier population, innovating to accelerate achievement of universal health coverage. One of the things I've noticed is in our conversation today, we focused on trying to address the things that a lot of conversations we've had before. So in this session specifically, one of the things I was looking forward to is learning how the PPPs in UHC in the space of innovation. So how, like in terms of data, what's happening to make sure that partnership is making sense? In terms of data privacy, I've not had those.
PPPs in innovation.
Yes, in innovation. Thank you.
We had that session yesterday.
Yes.
It was very well discussed, but thank you for that. We've noted your concerns.
Doctor, as you stated, healthcare is a very complex space to operate in, and we thank you for your diligence. You spoke about outcomes. What are those top 5 outcomes that you would have us focus on as leaders, as potential change makers, as governments, as health institutions? On which levels? Public health level, down to the individual hospitals or care centers, that you would have us to focus on that can create some sustainable quality of care that, at the end of the day, focusing on those particular outcomes that you mentioned, maybe not in particular, but why would you pick those outcomes to use as an overhaul for the system?
Okay.
And how could that really impact the patient care?
Okay, I can see.
We can answer that first, and then we can do a round 2.
Okay, so I'll ask Dr. Jyoti going down to my right. Do you want to pick the question, one of the questions?
Yes, I do. And you can correct me if I'm missing anything.
And very briefly as well.
Very briefly, right? As we talk about sustainability, as we talk about all these things, somebody asked who is failing us. What we know is that the public is the one who is failed, isn't it? There's unmet needs, and there are major unmet needs. We really, even as we try and point fingers on who is failing us, what is really, really important is for the public sector and the private sector to have open dialogues on how we can achieve these needs. Believe me, nobody wants to turn away a patient.
Absolutely.
No, we are all doctors here, right? And we've all taken oaths. Nobody wants to turn away patients. And believe me, no one does.
Thank you. I think you all need to move to Murang'a County. Because the Mamambogas in Murang'a County, 40,000 of them and their households are funded by the county. It pays SHA on their behalf. And they go through vetting, through digital platforms, so that the indigents are the ones who get funded. And if you look at the design of SHA, it was all of us who are able to pay, should pay, and the government should fund those who cannot afford to pay. While I talked about equity, that is covered under that pillar. So we need to hold our governors, our national government accountable to increase both the resources for healthcare and the efficiency with which they are used. Because we have two problems. One is we need more money, and secondly, we need to use the money we are given a lot more effectively. We have waste, and one of the key areas of reducing waste is digitization. Those who deal with private insurance, the paperwork the patient goes through, the facility goes through, the insurer goes through, adds about 15 to 20% on the cost.
Dr. Baraza?
That can be eliminated or reduced.
Thanks, Dr. Kakombe. I just wanted to mention two things. One is that health is what we call an open system. Sometimes we don't have a direct relationship between inputs and outputs because there are many variables that go into something. But one of the things that I know very well is that a health system that is well financed, forget about who is financing it, a health system that's well financed is likely to give you good quality care. And what does that mean? What that means is that we must have good governance systems in place. If we don't have good governance systems in place, then you will all want to go to Murang'a now. When the governor is out, maybe things will change. So we must put in place systems that go beyond the current governor for Murang'a. But then how can other governors also help what Murang'a is doing so that you can move on the same page? Thank you.
Dan Wala?
I think if we go the pooling of funds that Terry mentioned and paying for everyone, we will have a more equitable healthcare system. The only challenge that comes with that is what we experienced during the UHC pilot phase. Crowding, human resource for health, shortage, lack of enough commodities, but with clear investment in that, we can achieve this. Where the money is, I want to add to what he's saying. We've seen in this country, we keep playing around with the fuel levy when government wants to do anything, something, when they want to build roads, affordable housing. Why can't we do it with health? I'm sure Gen Zs will not go on street because the fuel levy has been increased to access free healthcare and a quality one. That is the comment I wanted to. And lastly, if you allow me, I think we also need to look at the benefit package. The benefit package for Mamamboga, like he mentioned, and a benefit package for who is paying more. are they able to access same services? Because diseases don't discriminate. They'll get a mama mboga and a person who is paying more. Will the person paying less get those services? Thank you.
Okay, we'll take 2 last burning questions, and you make it the direct question, please.
2 quick questions. The first one
please.
One question.
Yes.
Okay. So one speaker yesterday said that there is a 900% return on investment when you invest in preventive and promotive care. So for your institutions, that your business model is based on curative, where does that fit in? And what are some of the things that you're doing in preventive?
Okay.
Please be brief. 1, 2.
My name is Charity, a lupus patient. This goes to the doctors from the private hospitals. I don't know if it's a question or a suggestion, because the public, private, or the government in UHC is planning to have bringing together maybe something like, if I go to Aga Khan Hospital, they are able to see my records, and if I go to Metropolitan, I have to start again to speak to tell the doctor 10 years down the line where I started. Is it possible for the private hospitals to do that first before the government does it?
Integration of medical records, yeah.
Thank you. Mine is quick. It's about how to raise funds for the PPPs. One of the issues we can do to get enough money, even more than the 500 billion Dr. Kakombe is saying, we can tax all companies providing alcohol in Kenya, all companies selling tobacco and cigarettes in Kenya. If you pollute water, because 75% of the diseases in hospitals are water related, if you pollute water as a company, whether individual or whoever, or even a count, if Nairobi City County government pollutes water, that water affects the health of the people, the county is charged and fined. And that money will be more enough for everybody to share. Thank you.
Okay.
Dr. Wanda, just Gen Z has to finalize this Q&A session. Guys, please remember to give us your feedback on the QR code and subscribe to the Nation e-platform. It's free for a week.
Good afternoon. My name is Brian Mwaniki, and my question goes to Dr. Gakombe. But I also would like to hear from everyone in the panel. I would like to hear your view on this. Because yesterday,
can't hear you.
Yesterday, Dr. Brian gave a suggestion that has been given by this gentleman, that instead of kuongeza taxes za kila mse amechoka na tax. But you want us now to pay the taxes. You want the people to increase their taxes so that you can cover the healthcare system. Mr. Austin was here, and he said that if the doctors are not paid well, ndio maana wanaenda Botswana, because the Botswana is paying well. It's paying better than Kenya. So is that the mentality that you are giving the students in university? So that me niko university, I'm doing medicine. Now you want me to graduate with the mentality that nikitoka and naenda kwenda Botswana because Kenya is not paying better. Okay. I feel like you are giving us a lot of theoretical solutions to the problems that we are facing right now.
Oof.
So I think you should be telling us what is the success rate of the plans that you have laid so far. What is the success rate of that?
Fair. That's a fair question. We have 4 minutes.
He has injected.
He has injected. We have 4 minutes to respond to this, and I want to give the panelists just 30 seconds to comment. I know, Gakombe, you'd want to speak more, and there were more questions to you, but 30 seconds as a final statement. You might not get to all the responses, but...
So I wanted to address the curative care and the preventative care.
In 30 seconds.
In 30 seconds, and really quickly. As an institution, we're really working very hard on preventative care, and we're offering now a lot of solutions when it comes to preventative care, whether it's the wellness packages, whether it's collaboration through PPPs, again, for early detection saves lives, and screening, and so on and so forth. And before we move ahead, I am really for the integrated health record systems, because even in our institution right now, between the 53 medical centers and the hospital, because of the EMR, a patient's records are very easily accessible, and absolutely within the private sector and with the public sector, if we can collaborate, that would be perfect. Thank you.
Danuala, a practical response, practical solution?
I would like to answer, what I've captured is primary health care is not lucrative as curative care. That is why most governments are running and away from investing in social determinants of health, because the returns ni kidogo huko. So if we push for preventive and promotive care, we will spend less, and we will strengthen even the capacities of our people to perform their duties, because we will not be going to seek medical care all the time. So we need to push for investment in addressing social determinants of health.
Dr. Chris, final statements?
Mine are just three. One is, as government, private sector, FPO, we must invest in efficiency models, period. If we don't invest in efficiency models, then no matter how much money we'll get, we'll still lose it. The second thing is expanding our tax bracket. And there are good suggestions that you have. We call them sin taxes. And it's happening in this country for heaven's sake. But probably just looking at what are the other areas that can be taxable, so that people can feel a bit more comfortable to give that money towards taxation. The third and last thing basically is investing a little bit more on meaningful engagement of the population, because I think most of us just don't get involved in the discussions around health. Then we just come to realize certain things are happening without our involvement. So how do we, as governments, as the population, have a more meaningful engagement of the population to design the products that we want to have for the population?
And finally, Dr. Gakombe.
Thank you. We need to expand the tax base. There are a lot of Kenyans who do not pay their fair share of taxes. So we keep focusing on the same overtaxed, captive people in payrolls. So the government needs to get out there and find ways of bringing everybody who should be paying taxes to pay. There could be a lot more money. Two, let's not be despondent. And it is important that we are students of history. SHA, which we are talking about, started off as NHIF. They were spending 90% of the money they collected on themselves and only 10% on benefits. We have pushed them to the point now they're allowed by law to only spend 5%. So my message to all of us here is that good governance comes from eternal vigilance and engagement. And it is important we continue to engage, to push for the changes that we desire. And it is not in vain, because if you go 15 years back, healthcare has moved from a non-priority to a top 4 agenda today. There's a lot more money, and there's a lot more capacity for our people. But we have to be relentless, and we have to be involved and engaged.
Thank you. And I know the audience sentiment across board is that next time we have more practical solutions. This is what we need to do, right? And I can hear people saying yes. One practical solution.
One practical solution.
As I called Zainab.
One, to demonstrate that we are making progress. 10 years ago, dialysis, kidney failure was a death sentence in Kenya. There was only Kenyatta to dialyze you, and that's it. And it cost 1 million shillings a year. Today, SHA is paying for any Kenyan who needs dialysis, every single day in facilities across government, county, faith-based, private. That's a practical example of what we can do if we pool resources and use them well.
Okay, thank you so much. I'm going to give it over to, Agana. Ngana is here. I'll hand it over back to her. Thank you, the panelists, truly for making time to be here. I think the audience sentiment is that next time, practical, but more importantly, I think we'll give next time the audience to just ask the questions and answer those directly more than anything else. But thank you so much. I hand it over to Ngana.
Thank you so much, Dr. Diana and her panel. Thank you so much. I was just checking the time, guys. Please, let's scan the code, please, guys, everyone. And request my panelists, if you've not enlisted to the e-paper, we're not talking about sustainability. So all of you, please, our last assignment is to scan the code, register for the e-paper. It's free for 1 week. This is a conversation that is going on digitally, so I expect us to continue the conversation. It's just that we are pressed on time. Thank you so much. Before you disembark, I will request the panelists and the moderator to take a picture for purposes of our in-house publications. And guys, we have come to the penultimate session of this day. Yes, please proceed, take the pictures. I hope, guys, you've done that. Can we have the QR code for the feedback? Munaniangusha, literally, because we cannot not talk to each other. So please, scan that code. Tell us what you like and you didn't like. We are a very liberal organization. Hakuna comment mbaya itazimwa. I can guarantee you for that. We live for those comments. And make sure you give us your feedback on how we can make these sessions better and bigger going forward. And right about now, clap for guys, clap for guys, clap for guys. Thank you so much. Thank you so much for being awesome panelists. And right about now, I'd like to invite our sustainability editor at Nation Media Group, Ms. Zainab Wandati, to give us the closing remarks.
First of all, I'd just like to congratulate all of you for making it to the end of this summit, sitting down for 2 good days. Si kazi ngumu. Mjipigie makofi nyinyi wenyewe pia. Particularly, who's been here the full 2 days? Who has been here the full 2 days? Clap for yourselves. It's not easy. And I understand there's some people who've come from very far to be here with us. I thank you on behalf of the Nation Media Group. I thank you so much for making time to be here today. So as we conclude this summit by the Nation Media Group, the Nation Health Summit 2025, I'm here representing the company, not just as an editor, but also as a Kenyan who shares the same aspirations for a healthier nation as everyone else in this room, which is why you all made it to be here today. And over these 2 days, we have engaged in very many profound conversations, both on the stage and off the stage and during tea breaks, all conversations around our theme towards a healthier population, innovating to accelerate achievement of universal health coverage. We heard from the ministry, we've heard from community workers, we've heard from private hospitals, and also public health officials, as well as from you, the public. And we've also heard from technology innovators who shared with us some of the solutions that could be implemented. And the diversity of voices has been matched only by the depth of the insights. What has emerged clearly is that Kenya stands at a pivotal moment in its healthcare journey, and the path to universal health coverage is neither straight nor simple, but necessary and urgent. And we have heard about the remarkable innovations in digital health, from AI-powered diagnostics to tuberculosis to telehealth solutions, connecting remote villages to specialists. The list was endless, and we've witnessed how technology can transcend our infrastructure limitations and extend the reach of our limited healthcare workforce. And we've confronted difficult truths. Who pays for healthcare? Questions like that. And also the challenges that our healthcare system faces, and the workforce crisis that leads to repeated industrial action, and the financing gaps that leave vulnerable communities behind. You had somebody ask about Mama Mboga who pays 300 if they'll be accepted in private facilities. We heard from the medical student who said, msijaribu kuniambia mambo ya tax tena. But most importantly, we've seen the power of partnerships. The public-private sector, civil society, government, technology startups, and established institutions all recognizing that no single entity can deliver UHC alone. So what is our clarion call as the Nation Media Group? Ours is simple. Health is not just a sector. It is a foundation upon which our nation's prosperity stands. And what we've learned from the COVID pandemic is that health security is economic security. The two cannot be separated. And climate change is hey, my goodness, my Africanness is showing. Climate change is showing us, climate change is showing us that environmental health is human health. And the rising burden of non-communicable diseases is proving that prevention is not just better than cure, it is more sustainable and more just. And we cannot build the Kenya we want without putting health at the center of our national agenda, not as a privilege for the few who can afford it, but as a right for all. So at the end of it all, we have 6 calls to action that I'd like all of you to take with you today. So we call upon, as the Nation Media Group, we call upon you to commit to these specific actions. The policymakers, we ask you to set aside financial health as an investment, not as an expenditure, and implement the reforms discussed here with urgency and transparency. The healthcare professionals, who are the majority in the room, despite the challenges that you face, and we acknowledge your challenges, we have covered many of your challenges, remember that your calling is noble. You are called to heal. So continue to advocate for better conditions while keeping patients at the center. The private sector, who just left the stage, innovation without inclusion is not progress. Develop solutions that reach all Kenyans despite the challenges that those Kenyans face or their financial status. Develop solutions that reach all Kenyans and not just those who can afford to pay. Can I repeat that? Ni inject 10 apple? Okay. Private sector. Your clarion call. Clarion call to private sector. Innovation without inclusion is not progress. Develop solutions that reach all Kenyans and not just those who can afford to pay. Development partners, and we've had many of the development partners coming on board here, align your support with Kenya's priorities and strengthen sustainable, locally owned solutions. Now, our call as media and the civil society groups that are in the room, we commit to hold all accountable while highlighting progress and solutions, not just the problems. Yesterday we said we are not here to tell the stories of misery. We tell that a lot in the newspapers. So we commit to also tell stories of solutions, not just problems. The citizens at large who are in this room, we urge you to demand your right to quality healthcare. Remember, the Constitution gives you a right to healthcare, emergency healthcare. So we urge you to demand your right to quality healthcare, but also embrace preventive measures and healthy choices. We had a community health volunteer who yesterday and today has continued to urge that prevention is better than cure. And if you haven't had an opportunity to walk through the exhibition centers here, we have a bunch of screenings happening because prevention is better than cure. So as we live here, the journey to universal health coverage is not a sprint, but a marathon, and we cannot afford to move slowly. Every day of delay means preventable suffering for Kenyans. And as the Nation Media Group, we commit to keeping healthcare at the forefront of our national conversations. We will track progress, highlight innovations, investigate challenges, and celebrate the milestones. We will use our platforms to ensure that the momentum generated at this summit translates into tangible improvements in healthcare delivery. And as I conclude, I remind you of the African proverb that if you want to go far, if you want to go fast, if you want to go far, good. So we're in this journey together. We walk this journey together. All the 6 groups that we've made a clarion call to, we are in this journey together. Because at the end of the day, our destination, the universal health coverage for all Kenyans, requires us to go both far and fast, but only together. And the only way to achieve this is by working together with urgency and purpose. So let this summit not be remembered merely for the quality of its discussions, but for the actions it inspired and the change it catalyzed. So I thank you on behalf of my team,
the editorial team that I lead, I'm privileged to lead. They're seated right here. Bridget Ngana is also part of this team. She's somewhere in the room. Please wave to this is the editorial team that brings you the health coverage. Nimesema msimame msalimia wa Kenya. Mnogopa? This is the team I'm privileged to lead. It's part of the team, it's not the complete team. So this is the team that curated the content you've experienced at this summit, and also worked tirelessly to put together the panels that you saw. So if you have any ideas on how we could have made the content better, how we could have curated the panelists better, please see Angela as you leave. Angela, raise your hand. Angela is our health lead on the team. So any story ideas you have, you think we need to follow, Angela is the person you need to see, and we commit to following them up. Besides the editorial team, we were also supported by the corporate affairs team and the events team. I saw Naomi somewhere in the room. Melen and team, Naomi, Melen and team, please wave to the crowd. They supported this event. The commercial team, Mary and your group, they also supported this thing because, as I said, you do not, if you want to go far, you don't go alone. So as the editorial team, we also have to work in support with everyone else. I thank you very much from the bottom of my heart. Thank you for honoring our call to attend this summit. Thank you for sharing your ideas with us. And I promise you, the coverage does not end here. On the first day, Monica showed you some of the platforms we have under our health coverage at the nation. We have the Heartbeat on TV, Afya Yako also on TV, the One Health podcast that Dr. Diana runs. We have the Healthy Nation pull-out that were on your chairs yesterday. The list is endless. And we're always looking for ideas, how we can make this content better and how we can tell these stories to resonate better with you. So if there's a story you feel we have missed or another product you think we need to add to the portfolio, please see the team and we'll be happy to do so. So on behalf of the Nation Media Group, I wish you a good evening and thank you once again. Tuonane tena next year when we put out another call for the Health Summit.